Good morning, ladies and gentlemen. I welcome you all to this early Saturday morning CPD program. My name is Dr. Jose Fashiru Imam, and I am the Secretary General of the Nigeria Society of Physiotherapy, Kano State Chapter. And in a few moments from now, we're going to start the program properly. Let's just wait for a few more participants to join the meeting. We are currently steady at 17 members currently online. We have well over 60 registrants, so let's wait for a few more to come online before we begin the program properly. So thank you very much, and thank you for exercising patience. Thank you.
Do you want to go to other daddy? You
Good morning once again, ladies and gentlemen. Um, Thank you all for showing up so early in the weekend. We're still trying to sort out some people having difficulties trying to sign in and join us on the webinar. But as soon as everything is sorted out, we'll begin the program properly. And this will be in the next few minutes. So please exercise a little bit more patience, and we'll be with you in the next few minutes, please.
Ya Allah.
Good morning once again, ladies and gentlemen. We are about to start the program proper. Um, as earlier advertised, this is a multi-specialty CPD program that is going to award participants 15 points covering both theoretical and hands-on domain. Additionally, our facilitators are experts in their own right, in their own fields. We have Professor Umar Abubakar Muhammad Badaru, who is also the chairperson of the NSP Kano Education Committee, and he's a professor of neurological physiotherapy here in Bayero University, Kano. We also have Professor Jibril Muhammad, who is the former Dean of Allied Health, Faculty of Allied Health Sciences in the College of Health Sciences here in Bayero University, Kano. He's a professor of cardiopulmonary physiotherapy. We have Dr. Awal Muhammad, who's an associate professor of neurological physiotherapy here in Bayero University, Kano. We have Dr. Mujahid Muhammad, who is a consultant anesthesiologist and interventional pain physician with experiences spanning a lot of areas, including business. He has an MBA. He also has a master's degree in anatomy. We also have Dr. Olowe, who is currently a deputy director of physiotherapy at the National Orthopedic Hospital, Dala. He is an expert clinician in orthopedics, physiotherapy, and pain management, and also a renowned instructor in orthopedic physiotherapy practice. We also have Dr. Muhyiddin Muhammad, who Musliman Bichi, who is also an orthopedic and pain researcher and expert. He is currently the head of department at the Dawakin Kudi General Hospital, and he also chairs the department's specialty committee on orthopedics and musculoskeletal pain, as well as pain management. So without further ado, whilst we wait for other participants to join, I would like to call on our first presenter who is currently online, in the person of Dr. Mujahid Muhammad Hassan, to start off his presentation. Dr. Mujahid, the floor is yours, sir, if you are ready. Thank you very much.
Assalamu alaikum warahmatullah. Good morning, ladies and gentlemen. It's actually an honor for me to be part of this wonderful CBD program. Topics well chosen. I want to thank those working behind it to make sure that it's a success. I would today being in the presence of very senior colleagues and friends. I will just be presenting an overview of the pain and pain physiology, which I am sure that as the day goes, further elaboration will be made on the clinical aspect of it. I'll be sharing my slides. It's the slide visible to everybody?
Yes, sir, it is. Please go ahead.
Yes.
Okay. I'll go with this outline. That's a brief introduction to pain and pain, then through the anatomy and physiology of pain, pain sensitization, factors that may affect pain perception, a brief introduction to the different types of pain, and then of course the conclusion, inshallah. Pain is one of the oldest medical complaints. We all know that most of our patients come to the hospital with either complaints of pain or other pathologies related to pain. And it's one of the most common languages, which is understood by every human being. Once pain is being mentioned, everybody has one experience or the other about it. However, despite it being one of the commonest complaints or one of the most common medical conditions we see around, it still remains a fundamentally subjective, and still we have no quantitative approach or mechanism or to quantify it. However, over the years, there have been a progression in the definition of it, starting from the meaning itself. The word pain came or derived from a Latin word which means punishment. And gradually over the years, it was initially just limited to the sensation of the noxious sensation which we have. However, in 2020, the new definition came up by the ISP, which defined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This definition is very elaborate. It's tried as much as possible to capture everything. Almost 4 decades after the first attempt at defining pain, which at that stage it was limited to just the unpleasant sensory emotional experience, which occurs as a result of either tissue damage or potential tissue damage. But that left behind a lot of gray areas, which included pain which happen or is being described with no known pathology or no known tissue damage. However, it's described in terms of that. And that's why in 2020, that aspect of that term resembling was included to the old definition, which was in 1979. This emphasizes that pain is highly subjective and undertreated. And it's basically a personal experience, which depends on several factors that may affect the degree of pain perception in different individuals. We might have two individuals with the same type of tissue damage. However, they report entirely different sensation. That sensation or that stimulation of the nervous system is the noxious stimuli, which is the nociception. However, the perception by the individual and the reaction to it is what forms pain. So nociception perception is forms pain. Hence, both of them are being described as different phenomena, each having its own entirely different aspect of in physiology. Based on that, pain physiology is very important for all pain physician for all health care providers that provide solutions to pain. By that, we can see this slight line which demarcates between, or this very small demarcation between nociception, which comprises of the perception of the pain, or that's the first three components of the pain pathway, which is the transduction, transmission, and then once it gets to the higher centers where there is perception, that now forms the pain. So that's why pain is always been described as a personal experience rather than a physiologic pathway that is common to all individuals. To understand the principle of pain, we need to just step backward. All of us have been, I'm very certain that all of us have a very good grasp of the anatomy of pain, but this just acts as a reminder or a foundation for the broad discussion we'll be having during the day, inshallah, by our professors and senior colleagues that will be discussing in subsequent parts of this program today. The anatomy of can simply divide the anatomy from the nociceptors, which are the pain receptors, which we have at the terminal end of the pathway. Then you have the neurotransmitters, then the spinal cord tracts, and the higher centers, which are in control of the perception of pain. So nociceptors are usually described as free nerve endings that sense different forms of changes, which may either be thermal or mechanical or chemical changes that occur as a result of tissue damage, which are most likely the release of some cytokines that result in generation of action potential in this nerve terminals. The pain receptors on the nociceptors we are usually distributed all over the different parts of the body in different forms and in different of concentration, and that helps in localizing the pain. Um, several factors might result in in stimulation of these receptors, and this might be as a result of tissue damage or illness at any site around the receptors. The initial process of stimulating this is basically a physiologic protective mechanism that um, prevents damage or further damage occurring, and it stimulates a cascade of actions which are protective at its initial stage. However, when they persist, this can become a pathology of its own. This receptors detect signals from damaged tissue, and this are as a result of release of chemicals, which include uh, different different chemicals such as the globulins, the protein kinases that we have, the arachidonic acids, histamines, nerve growth factors, substance P, calcitonin. We will see the different factors and how they tend to affect the stimulation of this nociceptors. We have different types of nociceptors, which are basically below the skin. They're the most important nociceptors that we have. If you can see from the diagram here, we have the C fibers. They come in different shapes and based on the location and the function they have and what they actually tend to respond to. Um, Basically, when we're discussing the pain pathway, we are more concerned with the fibers, which are the nerve fibers, which are responsible for the transmission of the impulse or the conversion of this chemical or tactile or mechanical stimuli into electric stimuli that is being propagated via the axons towards the central nervous system or towards the spinal cord. Most of these fibers have their axons at the dorsal root ganglia, and they are sorry they are bodied the soma at the dorsal root ganglia, and they have axons which are in the direction of the periphery, and this helps in propagating the stimuli from the skin or from any viscera around where the stimulation occurs towards the spinal cord. They come in different forms or in different sizes, and they are being classified into based on their characteristics. Most of the fibers, as you can see in the diagram, we have the C fiber, which is the smallest. These are basically unmyelinated, and because of the unmyelination, as we all know, the propagation of action potential across their axons is usually very slow, and they are responsible for once adequate threshold of stimuli activates the action potential, and then they transmit impulses in a dull manner, slow, dull manner towards the higher center, and hence they're usually the nerve cells which are responsible for the sensation of dull, aching pain that usually comes after the sharp pain, which is propagated by other nerve fibers, particularly the A delta fiber, which are also small in size. However, they are lightly myelinated, and they have a slightly faster conduction rate than the C fibers, and they are mainly responsible for generation of action potential when they respond to heat, pressure, and some chemical release at their free terminal endings. They have this characteristic sharp sensation that is being propagated along the pathway towards the higher centers. Other fibers which we have are the beta fibers, which are the larger fibers. They are heavily myelinated, which of course would mean that they are much faster and they have a lower stimuli threshold. And their major responses to light touch and proprioception. And this um, are found mainly they are found mainly to respond to in the muzzle layer or in deeper layers there. Uh, you can see the different structures that we have there at the diagram below, which shows the level of myelination between the two of them. Most of our discussion while describing the pain pathway will be concentrated on the C and the A delta fibers, and we might briefly go discuss the A beta fibers when we are talking of how, or when we're discussing how the uh, the gating mechanism actually functions. In this diagram, we see that those free endings, the axons have this, like I mentioned earlier, have their cell bodies at the dorsal root ganglia, and they now continue towards the dorsal horn, where they terminate at the lamina, the different layers of the lamina, and this forms what is known as the first order neurons. This will synapse with either interneuron fibers or with other neuron fibers that form the second order neurons, and they have they form they all come together to form tracts that ascend towards the higher centers. Nerve fibers at this stage, while entering into the dorsal horn, some fibers will actually migrate upwards or downwards for um, one or two levels ahead. And that explains why sometimes the pain is maybe poorly characterized, as the entrance um, towards the uh, towards the spinal cord might not be exactly the same with the point of pain. Um, this is both a protective mechanism and also one of those mechanisms that help in ensuring continuous localization of the pain fibers. The first point of synapse between the first order neuron and second order neuron also is a point where later on we'll see that the descending pathway from the higher centers also synapse there to give some as an inhibitor to the conduction of the stimuli um, generated from the pain at the nerve free endings. When we have there's this organization of the nerve fibers at the spinal cord in such a pattern that we have the A delta myelinated fibers, which we had mentioned earlier, are quite a bit faster than the C fibers, and they are responsible for the propagation of sharp pain in a faster manner than the C fibers. They tend to have um, their first decussation at the lamina one, which is the which is the first layer of the rex lamina. Okay, the spinal cord is divided into some functional demarcations, which from 1 to 10, and each of them has its own function. Most of the time, we have the 2 and 3 as the substantia gelatinosa, which is responsible for the site of synapse of our C fibers predominantly, and some of the A delta fibers. However, most of the fibers that the C fibers have, they're arranged to be at the most lateral position of the dorsal horn, so their entry is towards the lateral part, and that sometimes is used as an explanation for why when there are any pathologies around the dorsal horn, most of the time the pain is being described as dull, aching pain, and occasionally having some sharp pain when it's further activates other fibers around it. The lamina 1 fibers directly decussate and towards the contralateral side and ascends in the spinothalamic tract as the neospinothalamic tract or the medial spinothalamic tract. Meanwhile, the C fibers have their first synapse at lamina 2 and 3, and some fibers spread out as the wide dynamic range fibers to lamina 4, 5, and 6, from where they now decussate, cross over to the contralateral side and form the lateral spinothalamic tract or the pliospinothalamic tract. The importance of this is that the A fibers are able to, and A delta fibers, which follow the lamina 1, are able to give more distinct and localized, better localization of the pain, unlike the other fibers which synapse at 2 and 3, and then have their fibers having interneurons to the extent with their second order neuron at other laminas, that is 4, 5, and 6, where they also receive some input from other muscular fibers from the ventral root and from other layers of the spinal cord, hence making it difficult to poorly localized and more diffuse when described when they are the cause of the pathology. As you have mentioned, once the spinothalamic tract decussate to the contralateral side, they start their pathway ascending upwards towards the higher centers. The neo spinothalamic tract, which earlier mentioned, is the second order neuron of the A delta fibers, which decussate at which synapse at the lamina 1, the first pain tract, and they ascend towards the thalamus, like as the name implies, and 99% of these fibers actually get to the cortex. And this majorly responsible for the immediate response we usually tend to have when pain is stimulated. So they are majorly protective. Meanwhile, the second wave of pain, which comes as dull, aching, poorly localized, or ascends via the paleospinothalamic tract, which is the slow pain tract. These are more medial, and the only 10% approximately reaches the thalamus. Most of these fibers tend to lay off at different parts of the brainstem and other limbic system before reaching the thalamus, and they're majorly responsible for the arousal that we might have. That's why sometimes when one is sleeping and then some form of pain is inflicted, one is able to wake up. Anybody that has any pathology within this part of the tract might not really be able to have the sensation that will arouse one, or the emotional aspect, which might be delivered from the limbic system associated with it. Several names have been used to describe this ascending pathway, but predominantly the most important pathways, ascending pathways, are the lateral and the medial spinothalamic tract, or which is the neospinothalamic, which is sometimes being referred to as the new spinothalamic tract, and it's responsible for the fast response we have. The old or the paleo spinothalamic is responsible for slow conduction, which gives the which is responsible for all the emotional, the sensational, and the conscious decision making and affection that might be related to that pain stimulation. The tracts usually have several components depending on which part of it's and are named depending on which part of the highest it tends to terminate. So that's why we tend to have in some literatures they will tell you have the spinomedullary, spinobulbar projection, hypothalamic, and these are all describing where the pain receptors terminate. And this explains the complexity of pain and how several factors come into play when pain sensation is being described or is being perceived by an individual, as different experiences might determine what the pain perception is. Here we just have a small description of a diagram just to give us an idea of where the each of these tract tend to pass. Just like I had mentioned earlier, the nociceptors go through the dorsal, that's for the neospinothalamic tract. Nociceptors to dorsal root ganglion, to the lamina one, that's in the spinal cord, then the crossover to the contralateral side and ascend of these fibers come together to form what is being referred to as the lateral spinothalamic tract. And they are arranged in such a manner that the most distal are more medial, and the most cranial fibers are in the most lateral aspect of it. And then from there they get into the thalamus part. That is the ventroposterior aspect of it. That from there they go to the cerebral cortex. That's the the sensory component of the cerebral cortex. This is the fast track, and we see that it's majorly, from the description of its anatomy, it's majorly responsible for the immediate response and the motor response we tend to have. So the function of each of these tracts can be detected from the arrangement of the fibers and where they terminate. Unlike the spinothalamic tract, which is more complex and is formed of several fibers. I had mentioned earlier, only about 10% of this fibers of this tract might get to the thalamus or the cerebral cortex. So the paleospinothalamic tract, on the other hand, the nociceptors go through the dorsal root ganglion, and then they initially synapse at the second and third, from where they tend to send multiple fibers through the interneurons to the second order neuron, which are found at the fourth, fifth, and sixth and seventh lamina. From here, 70 to 80% of the fibers tend to decussate to the or cross to the other side, while 10 to 15% in some individuals ascend without crossing to the others, to the contralateral side. This tract are now rearranged based on their areas of termination. So we have the spinal mesencephalic, and then spinal reticular, which is concerned with arousal, then spinotectal, and we have the spinothalamic, which is around just like 10%, spinohypothalamic, which is responsible for the affection and for the the conscious decisions that are attached to it, and they end at different components. They have a wider range of termination, starting from the limbic system to the cingulate cortex to the hypothalamus, basal ganglia, and then a very minimal number of them get to the sensory cortex, the second sensory cortex. A third uh, ascending pathway is also being described. It has almost the same similarity with the paleospinothalamic, and in significant number of books, it's been described as being part of the paleospinothalamic tract. But however, this has multiple synapses. They have multiple areas of synapses on their tract, and then they have a bilateral pathway. Most of the time, this tract is responsible for the inhibitory pathway, the ascending inhibitory pathway, unlike the ascending pathway, which is basically an inhibitory pathway, and it also has a diffuse distribution, starting from the prefrontal cerebral complex, and then the periaqueductal gray. So, in addition to the hypothalamus and the limbic system, where they are responsible for predominantly inhibition of further excitatory stimulation in this area, or generation of inhibitory stimulation, which is being propagated down via the descending pathway. This just describes some of the areas in the higher in the brain, which are responsible, which have different functions. And as you had mentioned earlier, these are the terminal areas which are responsible for pain perception, and to some extent also the modulation of pain. And each area has a different function. So I won't go into details of each of these areas, but the color, it's color coded, where you have the motor area, the sensory area, and which you can see are responsible, and in the cortex, which are responsible mainly for identification. The sensory area one is predominantly responsible for localizing the area of the pain and the intensity of the pain. Meanwhile, area like the second somatosensory cortex, it's mainly has the responsibility of identifying whether the pain is actually pleasant or unpleasant. This it does with other parts, such as the prefrontal cortex, and then the cingulate cortex. So it's, if you can see, it's given denoted as in purple color. Other parts, which is, for example, the thalamus, is also responsible for decoding the intensity and then receiving the input, identifying the exact area of the brain where this pain occurs. Similarly, we have the M1 area, which is predominantly a motor, and M1 gives you that immediate withdrawal. That's immediate withdrawal that one performs whenever when we have pain stimulated at a specific area. That is being controlled by the M1 area, while the SMA area, which is the subsidiary motor area, is responsible for the definitive movement to be done. That is to either to escape or to have a definitive movement on what. The first is a reflex, that the M1 is responsible for the reflex, while the SMA is responsible for the definitive movement that accompanies or associates with pain. If we look at the the amygdala and the hippocampus, which are the areas around are responsible predominantly. They are responsible for that emotional value, and they contribute more when it comes to chronic pain, where any abnormality in this area or in the interplay or the balance between the inhibitory and the excitatory functions in this pathway results in the maladaptive pain that occur, and the emotional aspect or behavioral aspect that accompanies the chronic pain sensation. On the other hand, you have the periventricular, that is the periaqueductal gray, and responsible for predominantly it secretes the natural opioids, which are the endorphins, and it's responsible for generation of the pathway. So when the ascending signals get to these areas, some of the signals are being transmitted downwards starting from the preaqueductal gray downwards through the descending pathway to give an inhibitory signal by the release of either norepinephrine or the release of opiates to activate the opioid receptors that we have along the spinal cord and at the a different level of the spinal cord. An explanation. This gives us a very a good explanation for why, despite the fact. Oh, sorry, I think. Okay. My apologies. I think I just got out of the screen share. Okay. This is why when a patient is anesthetized, occasionally patients that we anesthetize and they are deeply asleep, not responding to any stimuli, we tend to see some of them that have not been given adequate analgesics to be tearing, and when using EEGs to see the electrical activity of the brain, we see an increased activity of the brain. Or sometimes they even have this responses, physiologic response like tachycardia in them, which is an evidence that just the loss of consciousness does not stop or prevent the perception of pain. Another evidence is during sleep, while a patient is asleep and any noxious stimuli comes about, it either wakes the patient or there is that sensation of a response sometimes, the non-awake response, which, for example, is withdrawal or scratching the area, which might occur even while one is asleep, shows the interplay between level of consciousness, the voluntary aspect of the higher centers, and how pain is being perceived, even while an individual is not fully awake. So this is just the same explanation to the different parts you had mentioned earlier, and it just shows us how each of them is each area of the brain is responsible for different functions. Like we had mentioned earlier, we have the sensory and the motor parts in the cerebral cortex, which receive input predominantly from the thalamus, and this usually comes from the new spinothalamic pathway and some fibers from the plius spinothalamic pathway, and their consciousness is poorly is here. Consciousness is not affected because they are majorly responsible for the primary reflex that accompanies pain. The thalamus, which is the main relay of the brain, that's where most of the sensation goes in first and then relays. That's the third order neurons. Most of them, especially from the neo-spinothalamic or pathway, and a significant number or a number from the pliospinothalamic pathway, they have the termination of their third order neurons in the thalamus, from where fourth order neurons are now spread to different parts of the body, so that the whole perception of pain comes, or the holistic approach or a holistic perception of pain comes into play. So the thalamus receives input from sensory pathways, reticular formations, and multiple other paths. Predominantly fibers from the neospinothalamic get into the or terminate at the ventral posterior and nucleus, lateral intermedial, while the third order neurons that follow the paleo-spinothalamic pathway have their termination at the non-specific thalamic nuclei, from where they now have their fourth order neurons moving towards other parts of the brain. We all know that the reticular formation is concerned with consciousness, and hence here it's what brings up arousal from pain. All the reticulospinal or spino-reticular pathways are responsible for the arousal and the conscious perception associated with pain, and they receive input from sensory pathways, and they have this aggregation of cells from all parts of the central brain. The other components which we had mentioned earlier are in cerebellum, and some parts have their feedback from higher areas such as the cerebral cortex and from other nuclei in the brain and the midbrain. Facial nerves, on the other hand, they have a special tract, just like the dorsal root ganglion is responsible is this location of the soma, or the cell bodies of the sensory pathway, sensory nociceptors and sensory neurons in most parts of the body. The trigeminal ganglia is responsible for facial. It's where the soma, or the soma body of the facial neurons is located. And that's why most of the time when we have anything with facial pain, we try to look at the roots or the pathway in relationship with the trigeminal ganglia. The descending pathway. This is predominantly the opposite of the ascending pathway. It actually descends from the supraspinal region, that's from the higher centers, which we had already mentioned, and predominantly they have the function of either suppressing or exciting the pathway, and they are arranged in a manner where we have the descending inhibitory pathway, which descends and then cross to the contralateral side at the medulla. Unlike the ascending pathway, which crosses or sits at the level of the spinal cord, here the descending pathway actually decussate or crosses to the contralateral side at the level of the medulla. And predominantly, it has its origin from the PAG, which is the periaqueductal gray, and then it now descends, which is the major area responsible for the secretion of the endogenous opioids, and then the RRVM, which is responsible for the release of norepinephrine, which has inhibitory and excitatory functions respectively, and then this goes down up to the area of they terminate at the level of L1, that's lamina 1, 2, and 3, at the point of first synapse between the first order neuron and the second order neuron, or the first order neuron and the interneurons, thereby either exciting and thereby stimulating the increasing the pain perception, or by inhibiting, thereby reducing the pain perception in those areas. Like we'll see in this diagram, the preaqueductal gray matter actually receives input from almost all parts of the brain: amygdala, insula, and the cingulate gyrus, which is responsible for the or part of the sensory cortex. And then, based on this interplay of all these areas, the decision made by the higher centers of whether this pain should continue or should be stopped is now sent back as a response to the primary or the first area of synapse, which is at the level of the spinal cord. And you can see that at this area, which is where we have the first order neuron synapsing with the second order neuron, this is where the descending pathway terminates, thereby either preventing the release of the neurotransmitters, or it inhibits the release of these neurotransmitters at this stage. This is just a diagram. I'm not sure whether it's quite clear for most of the people. It seems a little blurry, but it just tells us about the interplay of the different components. We might see this at some other slides ahead of us. So the physiology of pain, having understood the anatomy of pain and how it's been propagated from the site of the noxious stimulus to the higher centers, and then back to the point of the synapse between the first and second order neuron to either inhibit or excite it. We would want to see slightly how this occurs, which is which is also referred to as the neurobiology of pain receptors. Of course, the nociceptors are the first group of the first cells or the receptors that identify. And this come in various, like I mentioned earlier, they come in various types and forms, depending on the area, and they are widely spread all over the body. We have those in the skin, which are referred to as the polymodal, and they are referred to as polymodal because they respond to various stimuli, starting from mechanical to thermal to chemical, and which results to the release of some neurotransmitters, and this results to the excitation or the which when they get to the threshold adequate for the stimulation of the voltage gated channels. This results to generation of action potential that is now being propagated along the neurons towards the higher centers or towards the descending pathway. Just to mention a few, we have in the muscles, we have the acid sensing ion channels, and this basically, the ASICs basically respond to change in pH that occur as a result of the stimulation, which might be from excessive exercise or from any other inflammation. These receptors here they are mostly what they call to as the silent receptors. They do not normally respond to pain stimuli, but when there's excessive stimuli, they tend to become active and then increase the perception of pain in those areas. Tendons also have free nerve endings, very similar to the those in the skin. However, here we have majorly they respond to stretch and inflammatory changes rather than different forms of stimuli. In the joints, we have many forms of nociceptors. Sorry for the spelling error, which are all around the joint, from the fat layers to the ligaments to the tendons, to the periosteum, and this explains how complex pain in joints tend to be, and management tend to be multi-stage to be able to identify the exact cause of pain and treat it. Um, Not forgetting the visceral body. Here they have afferent fibers, which are mostly associated with sympathetic and parasympathetic pathways. Most of the visceral pain being propagated along the vagus nerve, and hence the response that we tend to have whenever we have pain. But this pain fibers carried, they have the same, usually the A beta fibers, or they are now carried along the sympathetic pathway. And that's what brings up the whole concept of referred pain, where you have pain in one organ, but because they share the same nerve or spinal level, the brain tends to perceive the pain, because the type of nerve fibers that propagates pain from this area are mainly myelinated and have slow conduction with very poor localization. They are unable to give exact location. Rather, it's just a pain that is felt at the area which shares the same innervation with these fibers. The diagram here shows some of the neurotransmitters or neurotransmitters that tend to be released as a result of injury. You can see the lesion resulting direct tissue damage results in the release of serotonin, prostaglandins, and bradykinins, which, in addition to activation of the histamines, which release histamines. This results initially to activation of just the nerve fibers at the tip, or the free nerve endings at the tip of the area of injury. However, gradually there is activation of other nerve fibers around, which result in the release of substance P, and this results in vasodilatation, bringing more inflammatory reaction around the area, and then increasing the stimulation that is occurring around the whole area, with widening of the area of pain perception in this group. So if we assume that this patient or this individual has a prick, a little prick, the initial release of bradykinin, histamine, and prostaglandin will result in that initial stimulation of the A delta fiber, which is being localized, or clearly, distinctly localized and perceived with immediate withdrawal. However, that dull aching pain that continues as a result of a complex stimuli, which results from the initial stimulus, in addition to the activation of other factors such as the degranulation of the mast cells, which result in the release of further bradykinin, histamines, and prostaglandin, and of course, the cell lysis also result in the release of the intracellular potassium, in making the milieu more acidic, with of course with resulting in that aching poly localized pain that might be felt over a long time. However, usually this is the protective type of pain, and it's most of the time, the acute form of pain. Persistence of that result in chronic pain, and which we would see how it tend to occur later. The description we had earlier of how pain is being propagated, or the nerve impulse or the stimulation that we feel at the nociceptor end, is being transmitted to the higher center. It's a very complex neurophysiologic process. Of course, all of it is what we term as nociception, and this is subdivided into four distinct components. We have the transduction, transmission, which is the propagation of the impulse from the nociceptor to the spinal cord along the ascending spinothalamic tract. All the process of inhibiting either at the ascending or descending pathway, or increasing the excitability of this stimulation is what is being referred to as the modulation. Modulation means we'll get to describe it further when we get there. And then the whole idea of the complex processing of this stimulus, which includes the perception, the intensity, the localization, the emotional aspect that comes with it, the reaction that one is expected to do, and then the storage of this information as in the memory is all forms a complex we refer to as perception. So these are the four components or distinct components of the pain pathway. As I had mentioned earlier, the transduction is just the activation of the nociception, which I had earlier described, which may result from any of the stimuli, which may include thermal or mechanical, occasionally chemical, and sometimes even extreme of temperature. That's either thermal or cold temperature. And this, as we had seen earlier in the diagram, stimulates inflammatory mediators, which may either come directly as a result of the damaged tissue release. And this, of course, just a recap, includes bradykinin, potassium, histamine, products of the arachidonic acid, and of course, which includes the prostaglandin and leukotrienes. This is the cascade of how these events happen, resulting in the stimulation of the nociceptors. We had explained the conduction, but just another recap is that once the stimuli or the pain stimuli reaches a threshold which is accepted, we now action potential is generated, and this is conducted upwards in the normal physiologic pattern of nerve conduction over nerve fibers, or depending whether it is myelinated or unmyelinated, which determines the speed at which it's being conducted, and then also, of course, the size of the nerve fiber. I don't think we would go into details of how it's being conducted, but it's the same description that we had mentioned earlier. And then the transmission is what is the different movement that we have. But most importantly, what we need to remember is that when there is repeated, not every stimuli. It has been mentioned that 85% of the stimulus which reaches the nerve endings are not being responded to, or they are being blocked by the brain assumes that they are natural and do not respond to them. However, when you have repeated or an intense activation of these C fibers, this usually brings some changes in the NMDA receptors, and this is what is being referred to as sensitization, where a small stimuli results in a well perceived response to pain, and the transmission occurs both ways, from the downwards from the first order neuron till it gets to the second order neuron up to the higher centers, and then from the higher centers downwards, and it can either be inhibitory or excitatory response. Here it's a diagram which shows the major chemical mediators that might come into play when we are describing transmission. Just like you had mentioned earlier, we have the cytokines, the bradykinin, the protons, and of course the products of the arachidonic acid, most especially prostaglandin E, which directly activate the nociceptors and induce response to pain stimuli. Then we have others, and this perform their function or also stimulate the nociceptors indirectly by activating the inflammatory cells. That's they result in the release of antihistamines or the degranulation of mast cells, which now leads to sensitization. Excessive production of stimulation resulting in the secretion of this chemical mediators may, on the long run, increase the sensitivity of the cells, thereby causing sensitization. The diagram here is just showing us how pain proceeding in the spinal cord comes down and then results in the cascade of release of glutamate, norepinephrine, substance P, and this all results in activation of the sodium-potassium channel, opening the gates for the influx of calcium. And this, on the other hand, result to generation of action potential. So if you can see that most of the voltage gated channels are there to enable the the stimulation of the N-methyl D-acetate receptors, which when at some point in time, continuous stimulation of these receptors might result in reduction in the threshold of pain, and this results in the persistent or continuous pain that may occur when there is either inflammation or repeated inflammation that might result in stimulation of these receptors. We can see some of the when the fast pathway or fast track results in the stimulation of direct stimulation of the NMDA receptor by the sodium, by the influx of sodium. Meanwhile, the slow pathway require the activation of the second messengers, which is CMP and PKA. And this results in a slower stimuli, which persists longer, but onset is slower, but the duration is usually longer in this group of stimulation. So we have the same stimulation, but each of them has its own pathway, and this is what determines the rate of propagation of this impulse, and then the duration of continuity of the impulse. On the other hand, we have the descending pathway, which is the inhibitory interneurons that are common, and they are predominantly function via the activation of the mu opioid receptors or the norepinephrine, which are both which prevent the uptake, or sorry, the release of the glutamate and the substance P. Just as a reminder, glutamate and substance P are the major excitatory mediators found in the spinal cord and the higher centers, most especially in the spinal cord. So its inhibition will result in inhibiting the sensation of pain or propagation of the impulse of pain to the higher senses. Pain perception. This is where the whole complexity of the function of the different parts of the higher centers of the brain, the amygdala, the hippocampus, the somatosensory cortex, the motor cortex, all come into play to shape what we feel as pain. So at this stage, the nociception now is being converted to pain. And this is why the same stimuli might be perceived as painful by someone, and then by someone else that might be felt as a normal stimuli without having to panic. In the higher centers, even panic, fear are all controlled by these centers, and they all come as a result of interplay of a lot of genetic, biological, and racial factors that might make, and environmental factors that might change the perception of the same stimuli in different individuals. Someone, a simple example, someone is used to walking on a sharp floor or on a rough floor without complaining, while another person, once he places his feet on that same floor, might complain of severe pain. So that's all an interplay of perception rather than an interplay of nociception itself. The same nociception is there, but the perception differs. This is just a diagram telling us what are the different factors that come into play in pain perception, starting from and a simple example is labor pain. When in some cultural background, it's believed that it's inappropriate for one to express pain, and you see that people go through the rigorous uh, experience of a childbirth without expressing any agony. Meanwhile, others are expressive of their pain, and uh, it's it's um, it's accepted. So environmental factors, anxious patients have already an activated, they have already stimulated higher centers, and this results in a higher perception of pain. Likewise, with fatigue, patient with previous experience. Simple example is a pin prick. If one pricks himself with a needle and he feels or an injection, the exposure to injection. First time it might be painful. Second time the pain is there, but it's accepted. It does not warrant others. With that exposure, they tend to have an exaggerated response to it. Support, which might be family or any support from around that might help one endure, especially patients with cancer pain. This is very important because they tend to have a different view of what that perception might be. So age, gender, culture all come into play. We won't go into details of that because of time factor. But the other diagram by side also tries to summarize the whole thing, that the context of what pain means, what is the expectation, and that brings the whole idea of placebo. A patient that believes that a certain practice or a certain medication will cure or relieve pain. Once that medication is taken, there will be a significant reduction of pain because the higher centers have been modulated to believe that this will result in less pain. Hence, the perception of pain is being modulated downwards, despite the existence or persistence of that noxious stimuli that is there. Mood, depression, anxiety, catastrophizing are factors that actually worsens the pain because this leads to an exaggeration of the stimuli and then increased sensitivity to those stimuli, and that thereby the patient tends to have a vicious cycle of pain, uh, further worsening or deterioration in the perception of the pain, exaggerated perception, which worsens the depression, and it continues in that aspect. Cognitive factors. This is where factors like hypnosis comes in. The pain is there, the noxious stimuli is there, nociception is still there, but a complete attention towards another factor or distraction towards another factor or distraction makes one unable to perceive because the centers are now focusing on another factor, thereby the noxious stimulus being on their plate. These are all factors that come in and makes the same experience or the same nociceptive experience being perceived in different forms by different individuals. During our course of discussion, we had mentioned most of the factors that come into play during modulation of pain. I had mentioned earlier the intensity of pain is affected by the state of mind, and of course there are some factors that are being released either endogenously or exogenously, such as the endogenous opioid produced by the CNS predominantly in the periaqueductal area, and this results to activation of the pain receptors or the opioid receptors, particularly the mu receptors in the spinal cord and then in the higher centers too, resulting in the inhibition of the transmission of pain. Other factors that we have there is the gate theory. At some point in time, I thought we might discuss it, but I think most of us are actually quite familiar with this issue of pain gate theory, or the different theories of pain. And this is predominantly in a simpler form, is when another stimuli results in the blockage of the sensation or propagation of a pain, sorry, a stimuli propagated by a smaller nerve. For example, when you have a needle prick or an insect bite, and one scratches over the area, that touch sensation is being propagated by the beta fibers, which are larger than and has lower threshold, and are being propagated by larger nerve fibers, thereby blocking the propagation of the the impulses from the A delta fiber, which is the sharp pain of the bite, thereby feeling a form of relief. It's the same thing that we also apply when we use capsaicin, which is the all formed in most of the balms by inhibiting the release of glutamate or substance P. This gives a tingling sensation, and it's also been propagated by larger nerve fibers such as the A beta fiber, thereby inhibiting or preventing the forward propagation of the impulse from the smaller fibers. This is just the inhibition the inhibition or excitation of the pain signals from the spinal cord to the higher center is what is being referred to as the neuromodulation of pain. This just tries to explain exactly what we had mentioned earlier. Here we have what is being referred to as the when the opioid come into play to block the propagation of the impulse upwards by either having the activation of the descending pathway or direct effect of opiates on the opioid receptors. Thereby, impulse is no longer propagated along the second order neuron. Here is a diagram eliciting the different inhibitory factors, opiates, the norepinephrine that comes into play, and then how the inflammatory factors also result in the stimulation of impulse propagation of pain. However, when there is more of the inhibitory pathway, this results in the blockade of the excitatory pathway, and then pain is being controlled or is being modulated. Here we explain the same thing, just trying to explain further the gate theory or the gate control theory, which I had earlier mentioned. And then, of course, during our course of discussion, we mentioned that the descending pathway comes from the periaqueductal, and then the major mediators in the inhibitory pathway is the glutamate, substance P, and the endorphins, enkephalins, which are the major factors that help in prevention of the activation of the efferent anti-nociceptive pathway. So at this point, we have seen how the normal propagation, what happens when there is excessive stimulation of these receptors. We have what we call the peripheral sensitization. This is when there is damage at the peripheral, that's from the dorsal horn downwards of before the spinal cord, where there is inflammatory response might lead to a continuous or progressive inflammatory response, might lead to an exaggerated or extended pain, even beyond response, even beyond the time of the inflammation. There might be healing, but because of either down regulation of the inhibitory pathway, or because there is stimulation of the neighboring or surrounding tissue, making them hyper-excitable. This results in continuous stimulation, and this is what is being referred to as peripheral sensitization. It requires an initial stimuli, either tissue damage or an initial stimuli that will initiate the pain. But however, it's because of the damage done in the pathway or the abnormality in the physiology of the pathway, this pain becomes either easily stimulated or it becomes stimulated for longer than it's due. This is what exactly happens when we have what happens in joint pains, osteoarthritis, in a significant number of low back pain, despite the fact that low back pain might fall into more than one group. But this is what happens when you have most chronic joint pains. The other form of sensitization is when there is damage at the peripheral side, and then the neuroplastic changes in the horn, the changes that occur at the dorsal horn here, and there is a constant firing at the dorsal horn. At that area where there is decussation of the first order neurons and the second order neuron with the descending pathway, either because there is blockage or of the inhibitory pathway, or there is excessive stimulation, or there is because of damage from there is a new order of nerve impulse propagation. This now results in a constant firing with either no inhibition or excessive excitation of the area, and this also requires an initial stimuli which results to damage before there is continuous pain stimulation. A very simple example of this is phantom pain, where there is injury to a specific nerve as a result of amputation of the limb, and then the brain still keeps getting the impulse that part of the area which is no longer in existence or no longer in contact with the patient is still being stimulated, resulting in pain at areas which have been amputated earlier. Then central sensitization is when no damage is actually been has occurred, or rather there is an abnormality in the function of the higher center, either in the thalamus or the cortex. This may occur as a result of either ischemic changes or toxin assault to these higher centers, and this results in a continuous abnormal sensation. And they are usually widespread and polylocalized because you don't have a specific area of injury. This now results in widespread pain. A typical example is fibromyalgia, which is difficult to diagnose, difficult to manage because of the usually unknown pathology or the usually poorly identified area of pathology in this group of patients. Here we're just describing the same thing I had mentioned earlier, but in the diagram below you can see that normal sensory generation results in normal amplitude of action potential generated here. But once you have hypersensitive or hyperexcitable, it results in excess stimulation, and then this excess stimulation is once it continues for a long period of time, even after the stimulation has stopped or the stimuli has stopped, there is still discharge which is generated either by any part of the nerve fibers, either by the axon or the damaged axon or the soma, or even by the terminals. That means even when there are no stimuli, there is still some form of excitation of the persistent form of excitation of the pathway, resulting in excessive sensitization. However, the last form is when there is actual damage to the tissue, and this results in malfunctioning of this neurons, thereby becoming self-excitatory, even without any stimulant. They tend to excite, resulting in spontaneous activity and continuous pain. And these are some of the mechanisms by which chronic pain tend to occur. So you have the first stage where you have hyperalgesia, where there's increased response to smaller stimuli, and then gradually there is persistent stimulation, non-inhibitory stimulation, and then this continues to become a persistent pain. The IASP in 2016 actually described peripheral sensitization as increased responsiveness and reduced threshold of nociceptive neurons in the periphery to the stimulation of their receptive field, which is exactly what you had described earlier. And this is just a small description of the different factors which might come into play to result in any of this. Like I had mentioned earlier, you can have lower threshold for activation of C fibers, which means persistent dull pain, increased amount of action potential with mechanical stimulation, upregulation of the excitatory G protein receptors. Then when you have mechanical factors such as internal compression, persistent mechanical stimuli, this is what we see in things like carpal tunnel syndrome, or sometimes even when you have discopathies that may result persistent compression and then making the nerves hyperexcitable. Increased size of neuroma, and this results in stimulation of not only the area which is active, which is which has tissue damage, but it now spreads because of the activation or the increased release of inflammatory mediators. This results in the activation of areas which are far beyond the area of the tissue damage that occurs or that occurred, and thereby making the pain more persistent and covering a wider area. And finally is the electrophysiologic, which is lowering of the uh, threshold. Like I had mentioned earlier, there's always a threshold for the activation of pain, for pain to be considered significant enough to activate. And when there's lowering of this threshold, it results in hyperexcitability of the pain. It's my apologies. We're almost about to round up. Um, Central sensitization is the same idea, but however, this time around, the excitation does not occur in the periphery, but rather in the central system. And usually it's as a result of, most of the time, there is a defect in the central pain processing associated with activation of the NMDA receptors. This results in either an abnormality with central pain processing, which results in central augmentation, or in excessive central sensitization. Thereby, the level of glutamate and substance P are usually higher than expected, resulting in a continuous stimulation in the higher centers. Just like I had mentioned in 2012, it is central sensitization occurs as a result of the nervous system going through a process called wind up. Wind up means activating cells around the or increasing the sensitivity to smaller stimuli, thereby causing a persistent state of reactivity in the cells. This is just an explanation of it. When you have some nociceptors, you have the silent and the active nociceptors. Here, almost all of them are silent when there are no stimuli. But however, with peripheral stimulation, some of the cells are now becoming, even when there is no stimuli there, some of them are already sensitized. So with any little, there is always, with any little stimuli, there is persistent generation of action potential. So there's a continuous feeling of pain. And then when you have the stimuli, mild stimuli, with only a few silent receptors, this gives you a full-blown stimulation, which which is exaggerated and is persistent. This explains the central sensitization, where there is diffuse pain sensitivity, and then there is reduced inhibitory transmitters. You can see that the inhibitory transmitters are now blocked out. That means there's a continuous disinhibition, resulting in persistent pain in this group of patients. Pain inhibition is just a description of what happens in the descending pathway. This is self-explanatory. I think at some point in time we had already discussed it. So what are the factors that affect pain? There are multiple factors that come into play like we had already mentioned when you're talking about the higher centers. This is just what are the factors that actually affect pain perception. This starts from inherent physiologic factors such as if there is any pathology, chronic illnesses, sepsis. This might affect the perception of pain. And then sensory, whenever there's the severity of the pain itself, the initial pain itself. Social factor, cultural and cultural factors are also very important because this tells you why some it's believed that some ethnicities or people with some certain cultural background have more higher threshold to pain, which is more of modulation of the perception of pain in this group of individuals. Uh, Psychosocial or psychobehavioral factors such as such factors such as mood, anxiety, all tend to increase perception of pain. And then individual cognitive factors. What does the pain mean to you? Simple things like in certain cultures, some form of pain is being considered as an evidence of being strong or of being able to take responsibility. In those group of patients, it's a group of the brain has already been modified to accept that as an acceptable level of as an accepted pain, and it's hence been subdued or subdued, and they are unable to or they do not have the perception of that experience as pain. Um, this means that whenever we're discussing pain, we're not only dealing with the pain, but we're trying to break all these factors that might also come into play with pain. So the question now is pain a clinical problem only? When you look at it, nociception results in a lot of sociocultural factors, and this tells of how significant and important it is to manage pain in a holistic manner. Pain is different from suffering. Unfortunately, most of the time we tend to look at it from the same angle. Pain can be there, resulting in deconditioning, a lot of mechanical problems, loss of brain tissue. However, if left, it might result in further worsening of those factors, resulting in cognitive impairment, learning abnormalities, even going as high as social withdrawal and increased risk of suicide. Hence, the significance of looking into all these factors whenever you're considering pain, not only the physiologic or the pathologic part, but also this biopsychologic aspect of and social factors that come into play when we describe pain. Before we end, we just need to know about the different types of pain. Uh, Most of the time we have this classification, the old classification of pain, which is based on many factors, either duration, location, intensity, or etiology. But most of the time, people consider pain based on duration. Either it's acute or chronic. Acute pain, you have trauma pain, headache pain. Usually, they are as a result of peripheral stimulation, and they're easily treated by breaking the cycle of propagation of pain upwards. However, there are other forms. When it goes to chronic pain, this is pain which has lasted more than its expected duration of tissue healing or more than 6 months. It's still a debatable definition. Some people will go to as low as 3 months. That depends on school of thoughts of each individual. But here we have clearly described, divided it into nociceptive, neuropathic, visceral pain, and we have examples of each of them. Most importantly is when we are classifying is looking at this, what is the etiology of the pain? We have the neuropathic pain, nociplastic pain, nociceptive pain. Nociceptive or inflammatory pain is usually as a result of inflammation, and we all have a good grasp of that, and mostly it's not of much of a problem, except when it is a mixed form, where you have acute on chronic or acute inflammatory resulting in chronic pain. This is very common, especially cancer patients, which may come post hepatic neuralgia, and some of them become very difficult for us to manage. And then the most difficult part is the nociplastic pain, which is initially called the central pain, which includes the psychogenic pain. It includes disinhibition in the higher centers result or thalamic pain. All these forms of pain, which in the past had several names, but any pain that has no specific pathology or trauma injury is classified under nociplastic pain. Neuropathic pain, we just brushed through it, is an interplay, either peripheral mechanism or central mechanism. The mechanism peripheral mechanism is usually as a result of either excessive stimulation of the nociceptors. When you have ectopic discharge, when you have some glial cells now becoming firing on their own spontaneously without having a stimuli as a result of damage that has done and healing process in the wrong direction. Electrolyte abnormalities. Patients come with body pains as a result of either one electrolyte abnormality or the other. So it's usually very important with patients with chronic pain for us to consider these factors. Or when you have neurogenic inflammation, which of course we all know is as a result of interplay between pro and anti-inflammatory mediators. Or when you have central pain, which is as a result of any stimulation from the spinal cord upwards, as a result of either cortical disorganization or reorganization, pathology or abnormality with the descending pathway, or neuroinflammation. All of these factors come together to cause nerve injury, and then in the healing process, this results to abnormal firing, and they usually come with this distinct pain that is characterized by either paresthesias or dysthesias, or dysthesias mainly, and it's to some extent it's electric-like pain occasionally happening. Meanwhile, the neuroplastic pain is when there is damage to either in cerebral cortex or the thalamus, in thalamic area, and these are usually very poorly described, poorly described, do not have any pattern, or they are in excess of the mechanism of its occurrence, and they occur sporadically. They usually form one of the major challenges for most healthcare givers that are responsible for pain management, and requires multiple interplay to be able to manage it properly. Even with that, they have higher tendency of being very resistant to management. Before we conclude, I always remind myself of this chronic, what is being called as the chronic pain cycle. It's the job of every health caregiver to break this cycle when, if ever, they would want to treat pain. If you look at it, it's a somewhat interplay of psychology, uh, and physiologic changes or pathologic changes, and then a vicious cycle that continues to happen. So this tells us that we have significant input from multi-specialities, different areas of fields of knowledge to come together to be able to break this cycle. The first cycle, you have anxiety. When the pain signal occurs, the brain becomes more focused on the problem, and this causes changes to take place in the nervous system, worsening. That is, now you have hyperexcitability or sensitization of the brain, and this worsens the anxiety, resulting in less movement, and then, of course, more changes and more pain will occur. On the other hand, is when you have pain resulting in guarding, muscle spasm, restricted movement, muscle weakness, loss of motor function, and then, of course, psychological unhappiness with or helplessness that comes with it, frustration that comes with it, which further sensitizes the central nervous system, resulting in more pain. So, looking at this, breaking these two cycles, usually is where the challenge faces most healthcare givers concerned with pain management. A take-home message before we end is, whenever we're looking at a patient with pain, if you look at the pain is just a small cycle at the middle, but both sides is flanked by the physical vicious cycle and the psychological vicious cycle, and this is just a, 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 a an, ex, an insight towards the management of pain. So we need to, whenever we are planning or looking into a patient that is suffering from any form of chronic pain, we need to look at the physical aspect of him, the psychological aspect of him, and then, of course, the little aspect of pain itself, which can be managed pharmacologically or non-pharmacologically. But the larger cycles are the physical, which is the backbone of management in most conditions of chronic pain. And then a usually forgotten part of the pain cycle, which is the psychological cycle, which most of the time we tend to underrate it or overlook it while managing patients with pain. Finally, I would like to say let's always remember that while we map the ascending tract and identify the neurotransmitters, the true frontiers remain the patient's subjective reality. So the patient, whatever the patient says is pain. And our goal is not merely silencing the neurons, but restoration of the function of the function in that and quality of life of the patient. In conclusion, I hope that at the end of this academic day, we live as true architects of pain relief, not just people that make diagnosis of pain or try to find out the exact location of where the pain comes from. Thank you very much. And sorry for the prolonged time I took from you.
Thank you very much, Dr. Mujahid, for that insightful and comprehensive presentation. The intricacies of pain and physiology and anatomy have been thoroughly discussed, and we sincerely appreciate the depth of knowledge you shared with us on the foundations of pain and the science behind pain. We will now proceed to the Q&A session, and anyone of us who has a question can drop it in the comments section, or can use the raise your hand, or you can use the raise your hand feature of Zoom, and we will take the questions one by one. So the floor is now open, but let's be orderly, please. So raise your hand, we will point you out, and you can unmute yourself and ask the question, or you can drop it in the comment section. Thank you. Questions and comments, please, ladies and gentlemen. Okay, we have a comment by Dr. Muhammad Mubarak, who thanks Dr. Mujahid for the great and detailed presentation. And he also comments that the gut-brain axis and pain signaling is a rapidly evolving area of research currently receiving significant research interests. And he also opines that the mechanism offers promising path towards integrated pain management. Thank you very much for that question. I don't know if Dr. Mujahid has something to say on that comment, particularly relating to the gut-brain axis, which is currently an exciting area of research in terms of what our bodies experience. Thank you very much.
Thank you very much once more. I think you've said it all. Pain management is now one of the most researched areas when it comes to to the generally the physiology of it, the pathology of it, and I think it's an area where it's still poorly understood. A lot of areas are not fully understood. A lot of even the physiology behind pain is still not only the gut, which yes, of course, it's one very important area that for a very long time there was an assumption that pain is not a major, it has no major innovation, but recently it's becoming an area, major area of research. I absolutely agree with you, and I hope people come up with collaborative researches to cover up those areas because of the ethnic changes, differences that we have, and we might not need to rely on results gotten from other environments. Thank you very much once more.
Thank you very much for the comments, sir. We're still waiting on more questions and comments. There aren't any in the next few minutes, few seconds. We'll call on the next presenter. So anyone with comments or questions to Mujahid, Dr. Mujahid, we will take them now, or we can take them at the end of the session if anything comes up. So without wasting too much time, I will call on the next presenter, who is Dr. Mohideen Suleiman Bichi. Okay.
Secretary General, we have hands up, please.
Okay, please go ahead, Dr. Tasnim.
No, that's Dr. Adamu Ahmad Adamu.
Okay. Please, Dr. Adamu, please unmute yourself and ask your question, please. Apologies, I did not notice your hand was up. Dr. Adam, please unmute yourself and ask your question. Okay, while we wait for Dr. Adam, we have a question. Okay, please go ahead.
Yes, thank you very much. Yeah, this is what I had wanted to say. I said, while waiting for Adamu to speak, let me come in. Probably he's having some challenges. Thank you very much, Dr. Mujahid, for that extremely, thought-provoking. I mean, I'm actually glued to my computer, especially due to the fact that for a long period of time, I haven't been able to have a recap of, anatomy and physiology of this sort. But my question have always been, I suffer from pain. To be honest with you, I suffer this some low back pain for a very long time. But while I don't know, I mean, it's just a question that I want to ask. Why is it that despite these very deeper understanding of pain, that well, anyway, perhaps the question will be answered in the next session anyway, but let me still ask so that it sets us more in motion. I'm talking about other ways of lessening pain, aside from medicine, aside from drugs. You realize that, sincerely speaking, that most of the modalities that we use, that we don't actually work out. Sorry, forgive me. It's not a criticism, but for me, this is my side experience. And I don't want to take the drugs. I prefer to take the other physical. So what's your experience in that regard? Is it that we haven't been following the protocol well, or what's actually the reality? I mean, this really, really, really pains me a lot. And I want to know perhaps and I know this may be answered in the next session, because we'll also be looking at the non-pharmacological management. But anyway, your own insight on this also matters to me. Thank you.
Thank you. Assalamu alaikum.
Wa alaikum salam.
Good afternoon to the participants. I would like to appreciate Dr. Mujahid for his dissection of what pain is all about, and telling us about the neurobiology, the neurophysiology of what pain is all about. So as physical therapists, because mostly we tend to do with pain, and sometimes the pain tends to limit our own intervention when it comes to managing our patients. Because as we all know, we are movement experts, and majorly we tend to deal with our intervention deals with movement. So sometimes the pain tend to restrict us from maybe performing some of the movements. It is an essential webinar actually, because we must know how to deal with the pain. so that by doing that, we can be able to overcome maybe the challenges that are facing on daily patients. So it is really, really a knowledge addition in the sense that we should know how to deal with the pain so that our patients can improve also, thereby making their life better in terms of maybe quality of life. Thank you so much. Please, I should be muted. I don't know my setting. I don't see a place where I can unmute and mute myself. Sorry,
Yeah, thank you very much, Dr. Adam, for that question, for that comment and question. Let's check the chat section and see. Everyone is thanking Dr. Mujahid for the amazing presentation. We do have a question in the comment section from Dr. Muhammad Ali, who thanks you for the wonderful and informative session. And he would like you to shed a little bit more light on how tribe and ethnicity may influence pain perception, sir. Thank you very much.
Thank you very much to my brothers and friends, Dr. Ashiru and Dr. Adamu. Pain, I would like to say, okay, pain and pain perception is one of the areas of knowledge which is still evolving, not fully understood, and a lot of researches are being done. If a simple definition of pain had to wait for 40 years before we could actually make some, right from 1979 to 2020, before we could actually understand that the initial definition was not accommodating all aspects of pain. Not until recent did we have a whole new classification of pain, which is the nociplastic form of pain. With that, we understand that that the knowledge of pain is still evolving, and of course, the management of pain is still one of the youngest areas of knowledge in healthcare generally, despite the fact that pain is the oldest symptom that has been in existence with man. One of my from my little experience with pain management, due to my interest in pain management, I've realized that one of the major challenges people face is the non-holistic approach to pain management. We manage pain from different angles. You have like I mentioned one of my last slides. The pain is just a small aspect of the whole problem or the complex problem. You have the physical aspect. You have the psychological aspect. You hardly find a setting where all the branches of knowledge come together to make a treatment plan at the same time. We manage patients from different angles. Where I practice now, we have some interventions for some nociplastic pain, which is spinal cord stimulation. Yeah, that gives you a prolonged effect of pain. But most medications are meant to subdue or to reduce the perception of pain. But the real pathology behind it is most of the time not being addressed by physicians. When it comes to the physical aspect, it's been done with better outcome. During my practice, my early years of practice in Kano, with pain, when I found out that most patients actually did very well when there is a more holistic approach. When you have your psychologist or psychiatrist taking care of the perception, the cognitive part, or the psychological part of it, and then the intervention or physician gives medications to reduce the sensation of pain during the physical therapy that they have. Patients did very well when they participate in a holistic approach. But unfortunately, that's still something that is far-fetched. We hope that with the growth of the specialty of pain and pain management globally, we will start seeing collaborations where you have a clinic where all branches of knowledge, does you have a physiotherapist, a psychologist, or pain psychologist rather, and a pain physician or a neurologist, all sitting down in the same consultation room to make a treatment plan for the patient. Before then, I think we might still be having challenges with the treatment. I hope that answers both Dr. Adamu and Dr. Ashiru's questions. Concerning ethnicity, it's one of those factors that is being considered as uh, uh, a confounding factor or a factor that may affect perception of pain. So it's not that it reduces severity of pain, but it's the perception of pain, how you feel about pain, how the brain interprets the pain. It might be related directly to the ethnicity. It might be as a result of the environmental factors. Historically, we used to know that the Fulanese had a very high pain threshold. But in recent years, we're seeing, with all due respect to my brothers and friends, the Fulanis, we've seen a different narrative where the pain perception. So most likely it's an interplay of environmental exposure and belief or cultural understanding of what pain is like. Somebody that has been moving around under very harsh conditions has gotten exposed to so much pain that the excitation or the brain might interpret some of the trauma that might occur as trivial and hence do not require much attention. This is exactly what we see with the military when they are being trained to endure severe pain. And that makes them more capable to endure some level of pain compared to other individuals that are not trained in the same line. However, there is no clear-cut answer to how if there is any direct relationship. But a lot of studies have shown that there is significant variation in pain perception and response to pain stimuli by different ethnic groups. I think even in Nigeria, a lot of studies have been done comparing different ethnic groups when it comes to pain perception, most especially in labor pain. I think I don't know of other fields, but I know that a significant studies done on comparing different ethnic groups when it comes to labor pain, and there were significant variations among some ethnic groups in the country, and they were almost always consistent in different studies. And I hope with the progression of the day and other speakers, we will get to know more and understand more about the factors that affect pain and how the management of pain is affected by the different ethnicities. I hope that answers your question. Thank you very much.
Thank you very much, sir, for your time and for the insights you've provided so far. Last but not the least, we have a comment in the comment section from Dr. Samina Ali Muhammad, who is asking if you could have some time next week to join us in giving a brief explanation on the mechanism of action of certain drugs used in pharmacological interventions for pain. So maybe he can reach out to you later on to speak on, to elaborate on this more. So for the sake of time, we are going to continue with the presentation proper now. We've heard so much from Dr. Mujahid, and we thank him for his time. And we're going to our next presenter, who is Dr. Muhyiddin Suleiman Bichi. Dr. Muhyiddin is an expert orthopedic physiotherapist. He is also the head of Department of Physiotherapy at the General Hospital in Dawakin Kudu, Kano State. Additionally, he is also the head of the orthopedic, musculoskeletal, and pain management group or specialty in his clinic. So we welcome Dr. Muhyiddin Suleiman Bichi, who is going to present on the concept of referred pain in physiotherapy practice. Thank you very much, sir. The floor is all yours. Thank you.
Thank you very much, Dr. Uzaifa. Sorry, is my slide visible?
Yes,
Hello?
it is. You can
Okay,
go ahead.
thank you. Thank you very much, Dr. Uzaifa. Good afternoon, ladies and gentlemen. It is a great pleasure to join you as a resource person today. My name is Suleiman Bichi, a chief physiotherapist with Hospitals Management Board, Kano, and I'll be presenting on the concept of repart pain in physiotherapy practice. Thank you. And here is the breakdown of my presentation. The learning objectives. It is expected that by the end of this session, the participants will have a better understanding of what repart pain is and its mechanism. And they should also be able to state the clinical features of repart pain and differentiate it from other types of pain in clinical practice. Also, in our respective clinic, we should be able to apply an appropriate assessment method with the aim of improving the quality of care we provide to the patients and also reduce the frequency of misdiagnosing repart pain among physiotherapists. Here is the introductory aspect of the presentation. Dr. Mujahid, the first presenter, has already introduced to us what pain is, where he described pain as an unpleasant sensory and emotional experience associated with, associated or resembling that associated with actual or potential tissue damage. This is actually the latest definition of pain. And he also described the mechanism of pain and, of course, different types of pain we have in clinical practice. So my presentation will focus on the most frequently misdiagnosed and misleading type of pain in clinical practice, that is a repart pain. So what is this repart pain? How does it affect the patients? And how does it influence our treatment plan? And why is the knowledge of repart pain even important to us as physiotherapists? So answers to these questions will be provided as the presentation progresses. Now let's get some facts about the pain and repart pain generally. According to studies, pain is actually the #1 reason why patients seek physiotherapy services worldwide. So for this reason, it is important for all physiotherapists to continue to seek more knowledge on pain and repart pain in order to improve the quality of care we provide to the patients. Of all types of pain, repart pain is the most commonly misdiagnosed type of pain in clinical practice, as equally reported by this study that up to 50% of cervical and lumbar spine pain is may be initially be misdiagnosed by clinicians. So not only physiotherapists, but all clinicians generally. So this highlights the need for a thorough assessment. And of course, I'm seeking more knowledge for repart pain and reparal patterns in order to reduce the frequency of misdiagnosis among the clinicians. Additionally, another study reports that repart pain is usually confused with other types of pain. And this is probably because of the diffuse nature of repart pen. It is complex referral pattern and sometimes normal imaging associated with repart pen. So sometimes when you request for investigation and it turns out to be normal, so the clinician may begin to think that the pen is even psychogenic. This is why, because the actual symptomatic site may not actually be the site of the injury or the source of the pen. So by definition, what is this referred pen? Referred pen is just a phenomenon in which pen is perceived at a location distant from the actual source of the pen or from the actual source of the pathology or injury. As we can see here, let's say the actual source of the pen is site A. So in referred pen, the pen will not be perceived here, but instead it will be perceived at a distant structure, let's say B. Or if the pen is, if the actual source of the pen is here, the pen will not be perceived here. Instead, it will be perceived on the other distant structure. So having known about the definition of repart pen, let's now explore some of the causes of repart pen. That is the mechanism of repart pen. How does it occur? Of course, several theories explained different mechanisms by which repart pen occurs. One of the theories is the convergence projection theory. This represents one of the earliest theories that explained the mechanism of repart pen, and it is based on the work of Stotch and Ross in 1888, and later continued by Roch in 1961. Although the effort of these scientists were criticized by some other scientists, but eventually this theory became the most widely accepted theory explaining the mechanism of repart pen. So what this theory says, it proposes that afferent nerve fiber from different tissues, the visceral organs and somatic structures usually converge on the second order neuron of the spinal cord. So this convergence causes the brain to receive mixed signals. So when the mixed signals are received by the brain, it will be unable to differentiate the actual source of the pen. So the brain will now project the pen to the more accustomed somatic structure where it receives pen signal most from. Here is the diagrammatic representation explaining the convergence projection theory. We can see this red line. The red line here represents the afferent nerve fiber from the lumbar region, while this blue line represents an afferent nerve fiber coming from the gluteal region. So the two nerves are from two different structures, but convergence of the nerves here in the second order neuron of the spinal cord causes the brain to now receive mixed signals, meaning not being able to differentiate whether the pen is coming from this side or is coming from this side. So because the brain is more accustomed to receiving signals from the somatic structure, it projects the pen down to the distant somatic structure. So you can see from this diagram that the pen is actually projected to the posterior aspect of the thigh. So the patient will perceive the pen on the posterior aspect of the thigh instead of the actual source of the pen. So you can see the actual source of the pen is here, but the patient is perceiving the pen here. So as a physiotherapist, we don't need to always focus on the symptomatic area, but also try to trace the actual source of the pain so as to treat the pain accordingly. The second theory that explains the mechanism of repart pain is the axonal bifurcation theory. The axonal bifurcation theory proposes that an apparent nerve fiber usually divides into two or more branches to supply different anatomical structures. So stimulation of one of the structures may actually cause pain to be perceived on the other structures. This is simply because the structures share the same spinal nerve segments. The next on the list is the embryologic origin theory. And this theory explains that repart pain occurs because some visceral and somatic structures share the same embryonic origin. Although the structures become separated during development, but they still maintain they still share the same neural pathway just because of that just because of having the same having been supplied by the nerve that is from the same segment. While the next is the overlapping dermatomes and myotomes theory. Dermatomes are parts of the or areas of the skin that are supplied by the same spinal nerve segments, while myotomes are group of muscles usually supplied by the same nerve segment. So the overlap between these nerves causes the repart pain to be perceived on the other structures that are supplied by the same spinal segments. So in summary, we can say that the convergence projection theory is the most widely accepted theory that explains the mechanism of repart pain. All other theories are supporting. So let's now explore some of the types of repart pain. Number one is the visceral repart pain. This is a type of repart pain that originates from the visceral organs. A pain that is originating from visceral organ and is perceived on the other structures, especially the somatic structures, is what we call the visceral repart pain. So usually the pain comes from the heart, the liver, the kidney, and other internal organs. But the pain is not actually perceived on those structures. Instead, the pain is referred to a distant somatic structures. The second is the somatic repart pain. This is a type of repart pain which originates from the somatic structures on the body, usually the joints and the other structures, and the pain is referred to distant structures. So the pain is not actually perceived on those structures, that's the source structures, but a distant somatic structure. The last one is the myofascial repart pain. This has to do with the trigger points. So the pain originates from the trigger points of the somatic structures and is referred to a distant structures. So here are some of the referral sites for the visceral repart pain. Let's take heart as an example. So any pathology coming from the heart may actually refer its pain to the medial part of the left arm, the left shoulder, or left chest and part of the neck and jaw. So the actual source of the pain is heart, but it refer the pain to the somatic structures. So the patients may actually be complaining of the left arm pain or left shoulder pain. And if we are not careful, we concentrate and we focus on treating just the symptomatic side, ignoring the actual source of the pain. So it is advisable, especially when we have elderly patients that complain of left arm pain or shoulder pain, we shouldn't ignore assessing the heart, because most elderlies have hypertension and other heart diseases that may not actually present to you with the complaint of heart, but the complaint or pain on the musculoskeletal structure. So we need to also think of the source of the possible source of the pain and assess it as well. The second on the list is lungs. Pain or pathology of the lungs may actually refer its pain to the cervical or part of the shoulder region. Because of the limited time we have, we may not actually take all the visceral organs with their referral sites, but I have a pictorial presentation summarizing all the visceral organs with their possible referral sites. Here is the heart, you can see it. And when a pathology is actually coming from the heart, the pain may be referred to the left part of the shoulder and the medial aspect of the arm down to the upper limb. So I recommend that all physiotherapists should have a bigger picture of this in their clinics to remind them of the referral sites, and this will make the assessment of repart pain easy. So, or you keep the picture by the side of your table to remind you of this. And we also need to revise our knowledge of pain and referral maps. This is for the visceral organs again. And this is for the somatic referred pain. We said somatic referred pain usually originates from the somatic structures and perceived on a distant somatic structures again. So this is specific to the facet joint and the cervical disc. So pain arising from the C2, C3, and C3, C4 cervical facet joints may actually refer its pain to the occipital region and upper part of the neck, while pain arising from C4, C5, and C5, C6 facet joint may actually refer its pain to the part of the neck, shoulder, and scapula. So the patient will present to you on an account of maybe neck pain, shoulder pain, or scapular pain. You also need to trace these possible sources of the pain. So you need to examine the facet joints, trace the facet joints, stretch them to see, to find out whether the pain is actually coming from those joints or the pain is local. The same thing with the lower cervical region, that's C6, C7, and C7 to T1 facet joints usually refer its pain to the shoulder, scapular, and upper thoracic region. This is a summary of the referral map showing the referral sites for the pain arising from the facet joints of the cervical region. And this is for the thoracic and lumbar region. We can all have a bigger picture of this, test it in our clinic. It will definitely help us in easing the assessment of repartment to avoid misdiagnosis of repartment that is frequent in our clinical practice. The next is the myofascial repartment, which we said the pain usually arises from the trigger points. These trigger points are small hypersensitive nodules that are found in a taut band of a muscle fiber. So when these trigger points are stressed, the pain is felt locally where the trigger points are, and the pain is also perceived at a distant structure. So here are 3 examples of the muscles with the trigger points and the referral sites. This is the trapezius. So a stimulation of the trigger point in trapezius usually refer the pain to the lateral part of the neck, jaw, temple, and sometimes behind the eye. So if patient presents to you with a pain on the trapezius muscle, so you need to stimulate this. That's to stress the trigger point on the trapezius muscle. So if the pain is actually perceived on these areas I've mentioned, so the pain is likely to be a referred pain. So this needs to be addressed accordingly. The next muscles is the levatoscapulae and sternocleidomastoid. So all other muscles have their trigger points and the pattern of referral. So we also need to have these trigger points and the referral sets of all other muscles. But here are the commonest muscles in physiotherapy with these trigger points and their referral sites. Earlier, I stated that some studies reported that some clinicians confuse repartment with radiating pain. So is there any difference between repartment and radiating pain? Of course, some novice physiotherapists will tell you no, but I believe that the experienced physiotherapist will be able to state the differences between the two. So is referred pain the same with radiating pain? No, they are not the same thing. Both differ in mechanism and presentation. I earlier explained the mechanism of repartment that is based on convergence projection theory. And while that of radiating pain is usually nerve irritation and or compression of nerve, so the mechanism differs. Therefore, the two should not be used interchangeably. Let's explore some of the reasons why clinicians confuse referred pain with radiating pain. Yes, radiating pain is the pain that is mostly confused with referred pain in clinical practice, not only in physiotherapy discipline. So the number one reason is the educational factors. Of course, lack of awareness or lack of knowledge on the referral maps, referral pattern, and referred pain contribute significantly to this confusion, and it leads to misdiagnosis of referred pain. So what we are doing now, the workshop, the self-development will be a solution to this factor that is actually causing the confusion. So we need to improve our knowledge of pain generally and the knowledge of referred pain in order to avoid these confusions and misdiagnosis, which affects the patients significantly. So the next factor is the clinical factors. Of course, sometimes when we request for investigations, all the investigations will turn out to be normal. Why? Because we already stated that the source of the pain is not actually, where the patient feels the pain is not always the actual source of the pain. So when you keep requesting for investigations on the symptomatic side, of course, all the investigations will be what? Will be normal, because you are missing the actual source of the pain. So this further confuses the clinicians to even start thinking whether the pain is psychogenic. So next on the list is the anatomical factors. This has to do with the overlappings and of course the diffuse nature of the referred pain, meaning that the pain is perceived on a distant somatic structure other than the actual source of the pain. Referred pain has important clinical implication in physiotherapy practice. Yes, it has important clinical implication in physiotherapy. This is because the main issue is that the actual site where the patient feels the pain may not be the actual source of the pain. So if as physiotherapists, we continue to focus on the symptomatic site, we may actually miss important important source of the pain, and that will lead to misdiagnosis. And when misdiagnosis occurs, of course, the intervention will be inappropriate, and that will definitely delay recovery, lead to persistent pain, and waste the resources of the patients. So understanding the mechanism of referred pain and improving our knowledge of referral pattern and referral maps will actually help us in making a correct diagnosis and will help us in taking a safer clinical decision. Also, this will guide will guide us on when to request for further investigation or to refer the patients to other team members for their assessment and input. We all have common goal. Yes, we all have common goal towards patients. So don't keep these patients too. If you are unable to find the source of the source of the pain, or the patient is not improving, or you are unable to actually, or you are not confident with your diagnosis, there are other team members available to help you. So you can invite or refer the patient to actually have a good assessment of the patient to avoid all these negative consequences that may follow. So let's now talk about the assessment of referred pain. Having known what referred pain is, its mechanism. So the most important thing is to learn how to assess it. And assessment of referred pain require a multimodal systematic approach, integrating both sound clinical reasoning, subjective assessment, objective assessment, and overall the knowledge of referred pain, referral mappings, and the patterns. So this will actually help us in making the assessment of referred pain easier. So let's begin with the subjective assessment. We all know that under subjective assessment, we ask patients to describe their conditions. They describe the pattern, the onset, the location, the quality of their pain. And we ask patients to do that without interruption. We don't interrupt them because the information is actually valuable towards a correct diagnosis. So we get the information from the patients, and that actually guides us towards diagnosing the actual condition of the patient. So let me share with you a concise spread of assessing referred pain. Let's begin with the pattern of referred pain. So all pain has its pattern. The pattern of referred pain is that it is diffuse and poorly localized. Yes, and it doesn't follow dermatomes. So let's explain this in detail. Let's use as an example. So if the patient presents to you with the pain on the arm, we said referred pain, the pattern of referred pain is actually diffuse and poorly localized. So if you ask the patient to locate where he or she feels the pain, the patient may not be able to do that, may not be able to pinpoint with his finger that this is where the pain is. Instead, the patient may use language such as, the whole arm is paining me. So the patient will not say the anterior aspect of the arm or the lateral. Instead, he will say the whole arm is paining him, meaning that the pain is diffuse and is poorly localized. Or sometimes the patient may use visual aid, like he will use his finger to cycle a broad area on the body part as the painful site. So by seeing that, you should begin to think of referred pain. These are some of the features of referred pain. But if you ask the patient to locate the actual site of the pain, and the patient put his finger on one part of the body and draws a straight line, not necessarily straight, just draws a line to the other part of the body, that pain is likely to be a radiating pain, because we said radiating pain follows dermatomes, but referred pain does not follow dermatomes. So this language and this visual presentation will guide you in knowing whether the pen is radiating or a referred pen. With regards to the onset of referred pen, it has a gradual onset, and it is usually, in most cases, it is non-traumatic. Yes, so if the onset is actually sudden, don't think of referred pain, because the onset of referred pain is mostly insidious in nature. The next is the location. So if the we said that the referred pain is always passive on a distant structure. Yes, distant structure. So as a clinician, how do you understand whether this pain is coming from other structure or is localized on that point where the patient is pointing at? So what one should do is to, with the knowledge of referred pain, one has to actually stress the suspected source structure. So if the pen is not reproduced on the distant structure, the pen is unlikely to be referred pen. But when you stimulate the suspected source structure and the pen is produced on a distant structure, so the pen is likely to be a referred pen. So let's talk about the quality of referred pen. We have different qualities of pen. We have sharp pen, we have stabbing pen, and we have shooting pen. We have dull pen. So the quality of referred pen is usually dull pen, aching, and usually perceived on the deeper part of the body. This dull pen means that the pen is having moderate intensity and is usually constant. With regards to the aggravating and provoking factors, aggravating factors are activities that actually increases the intensity of pain. while provoking factors are activities that provokes the pen or starts the pen. So usually referred pen is not associated with activity. So activity does not actually always increases the intensity of referred pen, unless if one is actually stressing. Yes, as a result of that movement, one is also stressing the source structure, so the pen will be reproduced to a distant structure. So also the pen is not relieved by rest. So most of the time the pen is usually constant. It's not increased by activity nor reduced by rest. So if you actually find this, the pen is likely to be a referred pen. Next is the objective assessment. When you are objectively assessing the patient, the neurological examination is usually normal in patients with referred pen. So when you check for the sensation, of course, the sensation will be intact and there will be no change in reflexes. There will be no numbness or muscle weakness. Why? Because we said referred pen, there is no nerve involvement in referred pen. So when assessing patient and you find that there is altered sensation or there is hyporeflexia or hyperreflexia, or the patient presents with numbness or weakness of the muscle, so begin to think of radiating pain because nerve is involved, probably irritation or compression. But in referred pain, usually most of the neurological examinations are normal, except in visceral referred pain. Sometimes patients present with the autonomic sign, things like nausea, sweating, headache, and dizziness. So if patients present with all these symptoms, so it is time for you to screen for red flag and probably refer the patient for more assessment and timely intervention, because visceral visceral organs are involved. If one is actually trained to stress the visceral organs, you can actually do that if you are trained to do that. If you are not trained, other team members are available. You can actually invite for the screening of the internal organs to know whether the pain is actually coming from those structures or not, or you can just refer the patient for second opinion. Next is the provocative test. So we said palpation of the source structure reproduces the pain on a distant somatic structure. So when you suspect that the pain is actually a referred, try to stress the source structure. Yes, you need to have knowledge of this referral mapping before you can be able to actually carry out this test. So if by stressing the source structure, the pain is not reproduced on a distant organ, sorry, someone should, yes. If the pen is not reproduced by stressing the source structure, so that pen is unlikely to be a referred pen. And this is how to do for a muscle: stretch the muscle. So if the pen is reproduced on the other somatic structure, the pen is likely to be a trigger point. That's my official trigger point referred pen. While for the joint, one needs to compress the joint, and if the pen is reproduced on the other part of the body, so the pen is actually coming from that joint. For the organ, one needs to stress the organ, and if the pen is reproduced on the somatic structure, so the pen is likely to be a referred pen. So generally, provocative nerve tension tests are usually negative. Yes, tests like straight leg raise, which put tension on the nerve, is usually negative. Why? Because referred pain does not actually involve nerve compression or irritation. So all the provocative nerve tests will usually be negative in referred pain. So another indicator is when you are treating the symptomatic site and there is no progress, begin to think of referred pain. Don't just keep treating the patient. If you have the knowledge of referred pain, so try to stress the possible structure that you think is actually causing that pain. But continuing to treat the symptomatic site with no improvement will just be like a barking a wrong tree, and the patient will not progress. So one needs to actually find out the actual source of the pain and address it. And as physiotherapists, we are trained to do that. We are not always to be treating the symptomatic area, but try to understand where the pain is coming from. Then you address the actual source of the pain, and the pain that is perceived on the distant structure will just go automatically. So this is a summary of the characteristics of referred pain. So when one finds these characteristics while assessing the patient, so the patient is actually likely to have a referred pain. So we said the pain is usually deep, aching, and poorly localized, and it is also diffuse and non-dermatomal in nature. Also, all neurological examinations are normal, usually, yes. And when pain is produced by stressing the source structure, not the site where the pain is felt, so that pain is actually likely to be a referred pain. Referred site is usually non-tender, or tenderness does not reproduce the same pain. Yes, of course, when you keep stressing the symptomatic site, the pain will not be reproduced because that's not the actual source of the pain. We also mentioned that it follows pattern of segmental convergence from the source, not actually dermatomal in nature. We explained under convergence projection theory that structures supplied by the same spinal segments usually share this pain perception. The last one is that improves when underlying source is treated, not referred pain. When you treat the source of the pathology, and the pain is depend on the symptomatic site disappear, that has confirmed that yes, the pain is actually a referred, not radiating or other type of pain. So how do we manage referred pain? Although I think subsequent presenters will take us through how to manage several types of pain, but the most important thing is that identifying the primary source of the pain is the most important thing. And we know that pain management is a multidisciplinary approach. The most important thing is to find the root of the pain, then several health professionals takes care of the pain, the psychologists, the psychiatrists, the physiotherapists, and the pain physicians. So it's a multidisciplinary approach. So this is my take home. At least if you cannot remember anything from my presentation, remember to read and keep the referral maps in your clinic, because that will help you, that will actually make the assessment of referred pain easy. And please, when the patient is not improving with your treatment, especially when you are treating the symptomatic site and there is no improvement, please refer the patient. Don't keep the patient. Thank you very much for listening.
Thank you very much for the presentation, Dr. Mohiddin Suleiman Bichi. Thank you for explaining the concept of preferred pain and what it means to actually experience preferred pain and the science behind its management in physical therapy, as well as the importance of referrals and referral in the course of managing a patient with preferred pain. So the next item on the agenda is questions and answers as well as comments. So if anyone has questions or comments that you would like to make, you can either post them in the group chat, in the chat section, or you can lift up your hands. You can raise your virtual hand and we will ask you to, you can unmute yourself to ask your question. Thank you very much. So anybody with questions, comments, please, now is the time to bring them up. Thank you. Appreciations are coming up in the group chat of the meeting. Dr. Chrysanthus and Dr. Simonu, thanking you for a wonderful presentation, sir. So we're waiting on comments and questions, please. Questions and comments, please. The floor is open.
Hello, Dr. Josefa.
Yes, sir.
You know, Prof. Badr will not be available for this presentation. I don't know.
Yes, we're going to open the group, sir.
Okay, okay.
Okay, ladies and gentlemen, as already hinted by Dr. Muhyiddin, Professor Umar Abu Muhammad Badaru will be absent actually for this presentation, and his section would be merged with the session that will take place on Saturday next week. And he's unavoidably absent because he's away on an official assignment in Lagos and official university business. He had wanted to be here, but unfortunately, his flight time and whatever really was not going to be very flexible. So we crave your indulgence and we apologize sincerely for any inconveniences. So we're still waiting on comments and questions. If there aren't any, we're going to take a 30-minute break back in. Okay, is someone trying to speak? Okay.
Thank you very much, Dr. Suleiman, for your wonderful presentation. I want to ask a question, please. Are you hearing me, please?
Yes, yes.
Yes, we can hear you.
Yes, I have two patients with an STD condition, syphilis. And this patient presented with joint pain. I mean various joints.
Multiple joints?
Pain, is it also, can we also say it's a referred pain?
No, you can't directly say it is a referred pain. Your decision will be based on the outcome of the assessment. So first of all, you need to assess the patient neurologically and musculoskeletal assessment. And it has to be evidence-based. You can't just say it is a referred pain or not a referred pain. without assessing the patient. It is actually the outcome of your assessment and critical thinking, use your knowledge of anatomy and referral maps to actually take decision. So just like that, you cannot say it's a referred paint. Now, what I advise is, you know the joints, right? So
Yes.
check the referral maps where trace the actual source of those joints. You understand? So try to stress the structures there. So if the pain is reproduced on those joints, you get me?
Yes, sir. Yes.
So if the pain is actually passive on a somatic structure, so the pain is likely to be referred pain. But since you said the pain is on the joints, right? Meaning
Yes.
it's likely to be a localized pain. Mostly referred pain is perceived on a somatic structure. Understand?
Yes.
So
Yes.
try to stress the joint. If the pain does not leave that joint, that's if the pain is only passive on those joints and it's not passive on any part of the body, so the pain is likely to be a localized pain. But if you stress those joints and the pain is passive on another structure, so the pain is likely to be a referred. But from what we have just mentioned, the pain may likely be what? A localized, because you said joint, but you need to stress the joint first. Then you assess it, right? Do provocative tests. So provoke that joint. So if the pain is reproduced on the other part of the body, so the pain is likely to be a referred. But if it is not perceived on the other part of the joint, so it's likely to be a localized pain. Thank you.
Yes. Thank you.
Thank you very much, Dean. We do not have any further questions currently. So we will go on break and we'll be back here in 30 minutes. It's now 1:15. So we will be back here in around 1:45 p.m. So thank you very much, ladies and gentlemen.
Thank you.
We'll be back at 1:45 p.m. Thank you.
Thank you.
Good afternoon, ladies and gentlemen. Yeah, welcome back to the NSP Kano fourth quarter CPD program. And we're going to start our next session in the next 2 to 3 minutes, let's say by 10 minutes to 2, because most of our people are not back, but we've sent notifications into the registration groups and they will all be back in the next few minutes. So we'll start off by 1:50, that's 10 minutes to 2. So let's all try to come back because Prof. Jibrin is already online. Hmm. Okay. As we can we can already see the professor's screen is already live. So we are about to begin. A brief introduction to Prof. Our next presenter is Professor Jibril Mohammed, who's a professor of cardiopulmonary physiotherapy at Bayero University, Kano. And he will be taking over the presentation right at this point so that we can end the presentation on time. So, Professor, the floor is yours, please.
Good afternoon. Assalamu alaikum wa rahmatullahi wa barakatuh. So I am delighted to be here. Oops, sorry. I don't know. I'm having some confusion. Okay. Okay. I prepared this presentation for the workshop with a view to enlighten us on some of the things that we often ignore. Personally, when I was asked to make this presentation, and I started to reflect and I realized that most times when we see patients in terms of cardiopulmonary, pain is not really one of the outcomes that we tend to focus on. Most times you don't get referral for managing pain, probably because these patients, more often than not, they have other bigger problems, or will I say other more complications. And in any case, they may be on a very high level of pharmacological interventions. So I actually thought that it was a very scanty area until I looked in. So pain, like previous presenters have spoken about, is quite elaborate, is quite important, not clearly understood, sometimes not well delineated. And as we can see during the course of this workshop, it can affect multiple systems, the sources, the pathways, and all of that. So the focus of my talk will mainly revolve around the cardiopulmonary system, that is in patients with cardiopulmonary disorders. And the talk is in 4 parts as presented in the schedule of presentation. And the first one is this, which is the pain in patients with cardiopulmonary disorders, the patterns you should look out for, the presentations, and how to do this assessment. And being a physiotherapist, we dwell more on the physiotherapy aspect. I intentionally left out the pharmacological and other areas. So like previously defined, pain is a common but often under-recognized symptoms, largely because pain is also individualistic. It's also a perception. From the presentation of Dr. Mujahid, you can see the line separating the perception and where the others. So in the cardiopulmonary system, you can have a pain arising from the heart, that's a cardiac origin pain, the lungs, the chest wall, the pleura, and the musculoskeletal structures like the spine, the upper back spine, the costochondral joints, and all of that. So you see a more complex situation in the cardiopulmonary system compared to maybe other areas of physiotherapy. It's really difficult to specify where this patient's pain exactly comes from, especially when you have a critically ill patient that you can't talk to. Then it becomes more complex in assessing the pain of this patient. But nevertheless, you need to be able to accurately recognize the pain patterns and be able to offer some form of differential diagnosis or differentials, because if you're managing a patient and the pain is not well recognized by you, you can do well to refer, like Dr. Muhyiddin mentioned. So we are used to pain in the low back as physiotherapists, and less of concern is given to pain from the maybe thoracic region of the body. But all patients come to you. Patients come for intervention. Patients are in ICU, you are managing. It behoves upon you to be able to identify areas that you can help in the management of the patient. You can contribute to the multidisciplinary team. And it's very important. One thing we often don't do is to assess patients' level of pain prior to our intervention, during our intervention, and post our intervention, and also document this. And I'm sure this has been stated earlier, about 40 something years ago, 40 years ago, 4 decades ago rather, pain was described by the International Association of Study for Pain as unpleasant sensory and emotional experience associated with actual potential tissue damage, or described in terms of tissue damage. And this was a recommendation from the subcommittee on taxonomy that was adopted by the Council of the ISP. And when I looked online as early as 2020, by Srinivasa et al., we saw a more revised definition, which is quite more concise, describing pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So what this is suggesting is that pain has a lot to do with the experience that the patient has and your capacity to be able to get out the actual level of pain. The pain threshold depends largely on how the patient feels or how the patient communicates, and also the system, that's the body system of the patient, whether the anatomical and the physiological situation that a patient has. Yeah. So I mentioned the major organs that we can have pain coming from in the cardiopulmonary system. And this is a broad classification of them into 4, whereby a pain can either be cardiac originating or pulmonary, musculoskeletal, and chest wall, or from other sources that are anatomically proximal to the cardiopulmonary system and exhibiting pains that can actually confuse you as somebody providing intervention or assessing or managing the patient. So cardiac pain, I'm sure everybody becomes more agitated when we see a patient pain that you are able to localize to the cardiac or to the heart. And this is largely similar, whether ischemic or non-ischemic. Ischemic having to do with reduction in blood supply to the heart. And often these pains tend to have a similar predictable pattern due to the shared nerve pathways. So the popular one that we've all been taught about in school includes angina pectoris, which also has different classifications on different subtypes, can either be stable or unstable, and acute, subacute, and whatnot. We will not go deep into this, but just wanted us to know that these are some of the areas that are responsible for the cardiac pain patterns. So more to that, or a bigger step ahead of angina pectoris, is myocardial infarction, whereby the myocardium actually sorry about that. I tried to send away the children from the room. So whereby the myocardium actually is already infarcted, leading to death of the heart tissues as a result of reduce or stoppage of blood supply. So there are other infective types like the inflammation of the pericardium in terms of pericarditis, then also aortic dissection, which refers to a situation where you have blood in the aortic wall as a result of maybe tear. So for angina pectoris, a patient will describe his pain as, in terms of heaviness, the pain is not sharp. It's usually very heavy, squeezing, retrosternal, radiating backwards from behind the sternum, and also radiating towards the left arm, the jaw, the neck, including the upper back, as you can see in the image attached. So, and sometimes this patient gets relieved by rest. Maybe is pain on exertion or with nitrates medication. And sometimes these patients are triggered also by emotional stress, maybe you give the patient, when a patient hears a bad news, suddenly he feels a very sharp, a very heavy pressure pain that's squeezing in nature on around the chest region, oftentimes radiating towards the left arm because of its proximity to the heart area, the jaw, the neck, and the upper back. So this article describes the pathophysiology of angina, and you can see how it progresses due to accumulation of vulnerable plaques, forming cell infiltration, lipids coming together. And in the end, you can have thrombus formation. And of course, this progress to the next example under the cardiac patterns, which is the myocardial infarction. So there are several articles, including those grading pain. This is a very old paper from 1976, where angina is graded from level 1 to 4 in terms of the physical activity that patients can do, in terms of limitation, whether it's marked, slightly limited, or complete inability to carry out any of the activity as indicated in the slide. So another big example is the myocardial infarction. Here you have the pain more severe, more persistent, more crushing, and also more diffuse. We localize for angina pectoris to some parts of the left arm, the jaw, the upper back, the neck. But here in myocardial infarction, the pain is more diffuse across the chest and more difficult to localize. So we are saying all of this because when you have patients that you are managing and you're able to see some of these things, I'm sure when we come to red flag where you are obliged to refer such patients, we'll hear more details. But it's quite important for you to be able to take the history of your patient, whatever intervention you are called to offer for the patient, and when you get ideas of such symptoms or clinical features, then you can make the appropriate next line of intervention for such a patient. So in the case of myocardial infarction, it is usually not relieved by rest, which differs it from angina pectoris, and it's also associated with nausea or sweating. So these pictures illustrate what do I say pericarditis could look like. And here the pain is sharp, it's stabbing, and is quite localized also in the left chest or in the retrosternal area. And for triggers, it becomes worse when a patient is lying supine, and better when the patient is sitting upright or leaning forward. So this is the last example about pain from cardiac patterns. We have aortic dissection, which is usually sudden, tearing pain radiating mainly to the back of the patient, and it is associated with BP differences, maybe from on the two arms. You have very large differences in blood pressure in the right and left arm. Then it's also associated with pulse deficits. So from the lungs, pain usually originates from the pleura or airways because the nociceptors are absent in the lung parenchyma. Lung parenchyma refers to the spongy area of the lungs, which makes up the major lung tissue that you see. Usually, these areas do not have nociceptors, so they are not able to transmit any impulse that is related to pain. So most times, the pain that comes from the lungs usually originates from the pleura or the airways. And that is the reason why the first is the uricin, which has to do with inflammation of the pleura, which is the sheath that covers the lung parenchyma. Usually there's the visceral and the parietal. The visceral lining the lung parenchyma tissue, while the parietal lining the inner thoracic cavity. Pneumonia also, which is the infection, usually in the lungs, and because of the contact with the airways, you can have symptoms of pain being elicited. There's also pulmonary embolism, which has to do with blockage of the pulmonary vasculature. When an emboli is dislodged from another part of the body, this is mainly visible clearly with CT, which is the standard investigating means. There's also pneumothorax. Pneumothorax has to do with air within the thoracic cavity, mainly following maybe a collapsed lung. So instead of you to have the lung almost filling the thoracic cavity, you can have one of the lungs maybe collapse, and you have a lot of air around the collapsed lung. So this can also elicit high levels of pain. So in pleurisy, which has to do with inflammation of the pleura, I didn't get a very good image, but you are able to see what a normal pleura would look like on the left, while on the right is an inflamed one with more swellings, with more accumulation of fluid or inflammatory agents. So these patients present mainly with a sharp, localized pain that is worse on inspiration, especially when the patient takes in very deep breath, or pain elicited with cough or sneezing. So a patient is sneezing and it's eliciting so much pain from the chest, you can suspect a pain of pulmonary origin. So these patients often present with shallow breathing. They tend to avoid the area where the inflammation is. So on auscultation, there might be reduced air entry. There could be a patient avoiding to breathe around that area, so you don't hear any movement of air from on your when you apply a stethoscope. Another respiratory disorder that is associated with a lot of pain from the chest is pneumonia, which, as you see in the X-ray, has to do with infection. And infection comes with inflammation, which comes with a lot of fluid accumulation. And on auscultation or percussion notes, you feel a dull sound resonate, and this is often associated with fever and cough, and this also gives a worse triggering. It's triggered as in worse pain is elicited with inspiration, as just like we mentioned for pleurisy. Pulmonary embolism, usually sudden, and as you can see from the CT, when a contrast is applied, it shows how the pulmonary vessel, that's in the lung arteries, can be blocked either by blood clots or thrombus that dislodged from another part of the body into the lungs. So, and this is usually associated with high levels of heart rate, tachycardia, and also dyspnea, causes a type of pulmonary disorder. So lastly, there's pneumothorax, which has an acute onset and usually unilateral, where the problem is, and it's associated also with breathlessness or decreased breath sounds on the affected side. And you can see the collapse of the right lung, in this image, showing where the blue area filling up the entire thoracic cavity, if I can use that. So pain can also come from the musculoskeletal area of the chest. And for these, there are three main sources of the pain. And there's the costochondritis, that is the junction between the cartilage and also the bones, the ribs, if I can use that. Then there is also the intercostal muscle strain. As physiotherapists, we deal a lot with muscle tear, muscle strain, and all of that. So we all know that the muscles of respiration, the primary muscles of respiration, are the intercostals and the diaphragm. So you could actually have injury to the intercostal muscles, causing a lot of pain, or tear in these muscles, or strain rather in these muscles, causing pain that may need some form of intervention. Then, of course, at the posterior, the thoracic spine could also have a lot of problem. We deal with a lot with patients with several types of back syndromes. So costochondritis usually presents as a localized tenderness at the costosternal junction mainly, which this is the sternal bone. So where the ribs approximates with the sternal bone at the costosternal junction can be a source of pain, which is reproducible with palpation in these patients. Then this shows image of pain at the intercostal muscles. You have the three intercostal muscles, the external, the internal, and the innermost. Of course, the external is more active during inspiration. And pain in the intercostal muscles tend to increase with twisting, movement, or deep breathing. You know, when you take in deep breaths, you have these muscles contracting to expand the chest in all the three dimensions. That's the anterior, posteriorly, laterally, and superior, inferiorly directions. So when there is any tear in the muscles, it will elicit a lot of pain. So at the back, you could have pain across the scapular region and also along the spinal column. So there are other sources that we should all know about that could mimic cardiopulmonary pain. So we all know people that have ulcer. Ulcer is from the gastrointestinal, but you can have it presenting like heartburn, especially when you have gastroesophageal reflux syndrome or GERD disorder or disease, which presents as bony retrosternal pain. When we talked about angina, we talked about the other pain from cardiac origin. We mentioned that they present also with retrosternal pain. So you can see this is a very important differential. Otherwise, you'll be misinforming other medical team members or multidisciplinary team members of a possible heart pain when you have not ruled out something from the GI. So anxiety, panic disorders, patients with hyperventilation-related pain. And this is hyperventilation is common in some chronic respiratory diseases, and also patients with dermatomal pain, like in herpes zoster. So there are different presentations that a patient can present with clinically, and one has to do with pain-associated symptoms, behavioral and functional presentations, and red flag presentations. So pain can accompany common features that we see in patients, like dyspnea, palpitation, cough, fever, sweating, dizziness, syncope, fatigue, or exercise tolerance. In terms of behavioral, a patient will be guarding the chest wall or splinting. Maybe somebody wants to cough, he has to use his hand to press a part of the chest to be able to cough. That is behavioral, or rather, will I say splinting. Then a patient can have reduced chest expansion in the part that is most painful. So this is giving us a clue that possibly one of the things to assess may be how symmetrical the chest is expanding. Then patients can present with anxiety or fear as part of expressing pain or lack of participation. I think the previous speakers have really talked about this in some form. There is the last talk today will be on red flags, so I will not dwell on this a lot, but you can have a patient with sudden severe chest pain, pain with hemodynamic instability. You have a patient with pain with high rates of maybe very high blood pressure or high pulse rate, or with neurological deficits. These are presentations showing you of something more damaging that might be occurring underneath, or a patient with sudden hypoxia with chest pain, and so on. So as physiotherapists, what is our role in assessing pain for patients in the cardiopulmonary axis? So this could be divided into different subheadings. Subjective is the first, of course, and also because previous speakers have really dwelled on the subjective aspect of pain. If I'm in a lot of pain, like most men in Africa would want to behave, you will not want women around you knowing that you are in pain, or your children, or your colleagues. So that makes pain seriously subjective in terms of what you get from the patient. But there is also the opportunity to physically examine your patient and even carry out some tests to really localize. And you can use the support of maybe already requested diagnostic investigations, like, for example, increase in lymphocytes or white blood cells is associated with the fact that it is going on that the white blood cells is attacking, which has could be tissue damage, and this is quite related with pain also. On subjective assessment, mentioned pain history. Most times, we do this as physiotherapists, take the history of a patient, and this has to do with all the questions you ask the patient. When was your pain? Can you describe how it is? That's a very big idea of what to expect. But also, there is the pain scale. Mariam, please, Mariam Aliu, please, you could mute. Something is coming from your side. Thank you. Then there is the pain scale, which I must confess that we hardly use, maybe due to high workloads and all of this. But these are some of the objective tools that are used in most centers that are quite developed, and it helps you to guide your treatment in a more objective way. So for history, you want to know how the pain started and what kind of pain symptoms is the patient exhibiting. Can it be localized or is it radiating? You want to know the character of the pain. What are the things that aggravate or relieves the pain? How long has the pain been? Is there a pattern? Is it more in the mornings or in the evenings? And what it is associated with generally. So a patient comes and says he has pain with only when he coughs, then that gives you a good idea of what direction to go to, or when it comes to palpitation, as we earlier mentioned in our cardiac or pulmonary pattern. So for pain scales, there are several options. The popular ones for us in Nigeria, I think, is VAS, but the NRS is also similar to VAS and can be used. And also the FACES pain scale, where a patient can also subjectively tell you the level of pain he is in, based on, but this depends largely on how educated the patient is and how well the person applying the scale is able to explain to such a patient. So the second leg is the physical examination, which generally is divided in 4 parts. Inspection, when you come to maybe the ICU and you have a patient that is unconscious. It's only by inspection, probably, or depending on the level of consciousness, palpation, then probably you could see if you can situate a pain or localize a pain symptoms that the patient has. So, and that's, okay. I thought there was a message. If you have any question, you can always ask through the chat box. So for inspection, you want to look at the breathing pattern. Is it shallow? Do you see the patient using the accessory muscles of respiration to breathe? And that can give you an idea on why the patient may be avoiding other areas, probably due to infection or due to inflammation of the pleura or pneumothorax. Then is the breathing labored. Then posture, a patient that is forward leaning, if you attempt to make the patient stay upright, if there is a lot of pain and the patient is always trying to lean forward, that also gives an idea of what maybe the kind of pain the patient may be in. Then cyanosis, having to do with a lack of adequate oxygenation or oxygen perfusion. Then asymmetry also in chest movement. So these are things that you can see and document to give you an idea as you proceed to assess your patient. Then you can also palpate. This has to do with placing your hands on the chest of the patient. If there is tenderness, the patient can react. Maybe a patient that sustained multiple, maybe chest injuries or bullet injury, you could palpate and look at the face of the patient or ask the patient how much of pain you think you can grade for such a patient. Then in pneumothorax, can palpate for tracheal deviation. If it's deviating towards the right, it means there's a collapse on the left, and vice versa. Then the image is also showing tactile fremitus changes, which can help you to differentiate probably if there is consolidation or effusion or not. So this has to do with asking the patient to talk, and the less fremitus you hear, it means there's excess air in the lungs. On the more fremitus you hear, it means it has to do with echo mechanism. When there is consolidation, then you feel an increased intensity of fremitus on the palpated chest. So for pleurisy, you could narrow your ideas or what may be wrong with the patient. When you hear pleural rub, I don't know, maybe during the hands-on, if it's possible, I can play the audios for pleural rub, indicating pleurisy or pleuritis. Crackle sounds, meaning there is consolidation in the case of pneumonia. It can also indicate problem from the heart origin. Then when there's decreased breath sounds, it could be due to accumulated air in the thoracic cavity, or when there's excess fluid accumulation, and also murmurs for heart origin. Then this is a percussion mode, which has to do with assessing level, whether there's consolidation in terms of the dullness, or when there's hyperresonance, when there's high levels of it. And the images on the slide is showing different areas where you can actually percuss on the chest, anteriorly and also posteriorly. So what are the functional tests that we can use to guide pain assessment? There is the 6-minute walk test. So you ask a patient to walk for 6 minutes. There is usually the standard reference that he should be able to walk depending on the age and gender. And if this exercise is terminated due to exertional pain or dyspnea, this can give you a very good idea of the problem that this patient has. There's also the box scale, which just looks like the VAS that you show to a patient to assess or to ascertain the level of dyspnea. I've talked about chest expansion measurement, posture and movement tests to determine musculoskeletal involvement. So you have a patient that you try to make him adopt different postures, and usually people tend to avoid where it's most painful. Of course, you can make use of existing investigations, maybe the ones that have been ordered by the medical or the surgeons or the medical team. And some of these can help you in narrowing down whether the pain is. So the reason why we're saying all of this, so you don't take off all the stress to try to manage a patient's pain that really is not something that is within maybe your purview, or something that is maybe musculoskeletal that then because every pain originating from a particular aspect will also have a tailored intervention that suits that aspect. So it's important to be able to really see that the patient doesn't have some of the conditions to rule out the possibility of other areas that you can really then focus on. So I've showed example of a CT scan showing pulmonary embolism, aortic dissection. Usually results from blood tests. Laboratory can indicate whether there's tissue damage by the presence of increased leukocytes, troponins. Then ECG can also show whether there's myocardial infarction, which is really associated with serious diffuse pain, ischemia, or inflammation of the pericardium. So this is to round up the first part of my talk. Cardiac pain are usually non-reproducible. They are really pressure-like, except for a few that I mentioned with sharp pain, and they may radiate to other parts of the body. You have in myocardial infarction more diffuse, more radiating across the chest. In angina, more to the left arm, neck, and jaw. Meanwhile, the pulmonary pain on the other side is more sharp. They become worse with breathing, especially with inspiration. So you ask your patient to take deep breath. If the pain increases, you can try to say, okay, this may be pulmonary related pain. Meanwhile, musculoskeletal related pain in the chest tend to be more reproducible with palpation. Maybe there is a costochondritic pain. When you touch it 10 times, the patient feels the pain 10 times. Or with movement, especially when it has to do with the muscle aspect, maybe the intercostal muscles. Of course, gastrointestinal, which can give a lot of conflicting aspects, has to do with meals and so on. So this, okay, I try to check if there are questions. I can't see any. So in summary, pain in the cardiopulmonary disorders can arise from multiple sources, each with a characteristic pattern, and effective assessment requires a detailed history of the patient. If you have the patient in ICU, you need to read the case notes very in-depth, very carefully, to get a very in-depth idea of what may be wrong with the patient and where to focus on and not. Then there are evaluation tools that really can be used, especially if you have a verbal patient, a patient that can speak. We need to start to change to apply some of these tools. And then you have to also be able to examine the chest of a patient. The skill is no longer an option if you're going to manage patients with cardiorespiratory disorders. You need to be able to know when the percussion note is done, when there's crackle sounds. Of course, this can be taught in an online workshop, but it's really, really important. You need to be able to recognize red flags so that you can call the attention of the next staff or personnel. A patient that suddenly loses oxygen saturation, or when there is hemodynamic imbalance suddenly, and all of that. So there's a need to be able to adequately and on time recognize red flags. Then you have to have a good understanding of lung and heart pathology. And I hope I have tried to explain this a bit. Thank you very much. I don't know if there are no questions, I will just proceed. Or Josefa, what do you think? Since I would like to do all of this before 4 p.m., then we decide we can come back on.
I think you can carry on, sir, because there aren't any questions currently in the.
Sorry, I have one. I'm sorry.
Okay, please go ahead.
Okay, yes, thank you very much, Prof, for that very insightful lecture. But then, sorry, insightful presentation. But mine is, I just want us to, well, forgive my naivety sometimes because perhaps I'm a bit disentangled from clinical practice for a long time. But then, I'm just trying to see the implication for the first contact with the therapist. You know, to be honest, there is a great shift in paradigm in how we practice as therapists. You know, given the doctor of physiotherapy program that is currently, running. I'm sure when you're talking about these clinical examinations, you made mention of, the idea that maybe, some of the clinical examinations been asked for by physicians. So I'm just concerned. I think we also need to be tilting our own discussions toward first contact with the therapist, because having that kind of perspective is also very important, because in the next 4 or 5 years, everything in the practice changes, because we are also supposed to be, serving as first contact with the therapist. I just saw today, the change in the entry points for pharmacists, with regards to this ongoing advocacy. And I'm sure very soon it will be the same for the therapists. So I just also want to call our attention that changing this doesn't come easy. I mean, it also comes with other changes. It also comes with expectation. It also comes with generally how we practice. So while we're discussing, I'm just calling our attention perhaps to be discussing as first contact with the therapist, so that ideally we should be speaking about what we should do. Do you require, let's say, clinical examinations? You order for it? How is it? Because I think this is also very important. And maybe in the long run and in other courses, we'll be taking, discussions generally on how first contact practice is going to be, because it is definitely different from the current practice that we are doing. Thank you very much for that. Sorry for forgive my naivety if there is, because I may be, other things that might be happening and I'm not probably aware. Thank you.
Thank you very much for your comments or contribution, if I can put it that way. Yeah, I realized this, but based on current realities, we also need to know that what you mentioned is a process, and it's quite a long process. But at the moment, what most international guidelines are also recommending is the MDT approach, which is the multidisciplinary team approach for most disorders. ICU is one area that nobody knows it all. There has to be some form of multidisciplinary training team approach to management of patients. And because these patients are not patients that you want to take a lot of risks with, so it's always good to double check. Actually, what I meant by existing, I just mentioned that because if you have a patient folder and you already have laboratory investigations inside, your ability to also decipher it is very important. And that comes with a lot of training that's at the moment suboptimal. So that is one area that we could focus on, because once people get all the skills and it becomes easier, then maybe the following steps, subsequent steps could be actually making requests. At the moment, we do a lot of requests for x-rays, but CT not yet, probably because also the costs involved. So there are a lot of things that won't really benefit from trial and error at the moment. But me as a person, I think the MDT approach happens to be the best idea, I think. Even among the physicians, it's coming up. Most international conferences, if you go now, you see if there is maybe a patient with interstitial lung disease, they want the radiologist on board, the person from rehabilitation or physiotherapist on board. They want the pulmonologist on board, if possible, maybe the rheumatologist. So unfortunately for us, our health system is not well structured for that. We all stay in our individual silos, and fighting for stuff like this would be like swimming against the tide. So probably if the one thing that is within our grasp is to train, but training is also difficult because if you only have a theoretical training, then how do you apply that clinically becomes a very big problem. So I think we can keep the discussion ongoing. But at the moment, if you see an investigation that's been ordered, you'd also try to read it, understand, and relate it with the level of pain, which was the message I intended to pass. I didn't say that we should at any point never be able to request for this or that. That would depend largely on the clinical competence aspect, of course. I hope I have tried to touch every part of the answer that I could give. There's no one straight answer to your comment or question. Thank you very much. So looking at the next topic, sorry, I don't know if there are further questions, but they could come along the line because I have everything on one slide, on one PowerPoint file, sorry. So we now want to narrow down to patients with critically that are critically ill, meaning patients in the ICU. And like I mentioned at the start of my presentation, I said when I was asked to talk about pain, I then realized that most of the time when in the ICU, we try to just remove mucus from the airways. We try to prevent ICU-related degradation or acquired syndrome post-ICU. We try to mobilize patients, that's get them sitting out on time, moving the limbs, sometimes maybe breathing exercise or chest expansion, percussion. We almost never think about pain. But there is pain. Everybody knows there is pain. And this pain, as a result of whether before the ICU admission or because of the interventions the patient received in the ICU, such as invasive procedures. Some of the patient has, maybe they had surgeries. Some of the patient due to prolonged immobility, maybe the patient is unconscious. This can lead to the pain development, maybe due to pressure area problems, like pressure sore. Mechanical ventilation itself, even though patients receive sedation, can be associated with some form of pain. Maybe the patient has underlying pathology, which is what I talked about, having it pre. So in ICU-related interventions in general, including physiotherapy, by the way, can elicit pain in patients. So, and this pain, if unmanaged, can lead to harmful physiological responses, delayed recovery, sleep disturbances, and poor long-term outcomes. We've seen studies whereby patients 3 to 4 years post-ICU still carry on with them what is referred to as post-ICU syndrome. So physiotherapists can also play an essential role in managing this patient within a multidisciplinary team. So I saw this paper online. It's a paper from, I can't see the year, okay, let me, from 1999, which is about 25 years ago. And they concluded that pain is common in almost every age group. I think it's a narrative review. And it can be expected to be seen in ICU patients as also a pre-existing complaint, because a patient may be undergoing surgery, maybe for lung problem, maybe lung cancer. Already the patient has pain. And post-surgery, the patient happens to be in the ICU. That pain is still there, or the source of pain might not have been fully taken away. So, but we also know, like I mentioned, that the pain can be as a result of events that brought the patient to the ICU. and those that occur as a result of ICU management. So the sources of pain could be medical, interventional, or musculoskeletal contributors. So conditions such as acute respiratory distress syndrome that will require a patient to go on ventilator can be a major source of pain. A patient that has trauma, maybe following road traffic crash or head injured, can be in a lot of pain. Patient with fractures, maybe to the chest or other areas, will be in a lot of pain. Patients with burns, maybe third or fourth degree burns, in fact, even the first degree, because of the nociceptors, be in severe pain. Post-surgical patients, depending on the surgery, maybe the incision lines, the suture area, maybe thoracotomy, can be in significant pain. Then patients with severe infections, pneumonia, pleurisy, and ICU can also have pain, as well as inflammation. Then ICU interventions that can cause pain. I think I've mentioned this. One very important one to us physiotherapists is suctioning. I'm aware not everybody has skill to adequately suction, but when you suction a patient and you leave the catheter too long, you can actually elicit a lot of pain in this patient, because when you suction, it can suction everything, including some of the good things from the body, like oxygen and so on. That is why it's important for ICU suctioning. You have to keep close eye on monitoring SpO2 and other parameters, because you can actually elicit pain when you think you are doing good for the patient. Then you have to be careful for the drains, the lines, the catheters that the patient is on, because at the chest drain, the mouth where the drain is can be tender, the central lines. So patients in critical care actually are very good candidates for a lot of pain. Then when you position patient, as good as positioning is, frequent turning can also lead to elicitation of a lot of pain, wound dressings, mobilization, maybe there is stiffness in the joint or in the shoulder, and you're moving it and your patient will be crying. That's a lot of pain that is as a result of ICU intervention, including exercise therapies. We don't really mention it as exercise therapies for our ICU patient, but in reality, we are giving exercise. Maybe you are mobilizing the patient out of bed and all of that. So these are interventions that needs to be done, but comes with a lot of pain for ICU patients. Then immobility is a musculoskeletal contributor to pain, muscle and joint stiffness, pressure, and that's why now in the ICU you see more mattresses of different quality, changing, more improvement. Then ICU acquired weakness. So what is the challenge with critically ill patients? Is the fact the number one biggest challenge is the fact that these patients cannot talk to you due to either they are intubated, they are sedated, or they're unconscious, or at best maybe confused or deleterious. So it becomes difficult to do a adequate assessment, but nevertheless, you have to do some form of assessment. Then physiologic behavioral signs of pain. A patient that has a high respiratory rate, heart rate, tachycardia, or hypertension, a patient that is sweating, even though we know the ICU environment can be cool. A patient that is agitated, we mentioned that pain also has to do with emotions, and that is why you see all of this. A patient resisting mobilization, even if the patient didn't talk to you, you know that maybe the patient is in pain. Then a patient with high respiratory rate or decreased compliance, even if the patient is on ventilator assisted breathing. So we've talked about these. So these are some of the things you can use for assessing pain. Then in the ICU, there is a critical care pain observation tools that has to do with facial expression, body movement, and this is very relevant for patients that you can't talk to, patients that are unconscious, muscle tension, ventilator compliance. And there's also the behavioral pain scales. I don't know. Okay, I thought I got the image. Maybe after this, I'll add it to the slide before sending the slide. Then during physiotherapy interventions, there's need to So in terms of the non-pharmacologic complication, complementary interventions for pain, we've seen a lot of proposal. This study published in 2009 on chest really explains the physiological basis behind our intervention. And this is related to the gate control theory of pain. We all know the pain gate theory or the framework. And it is based on that that our management is supposed to be anchored upon, whereby we inhibit ascending transmission of noxious stimulus from the periphery and also stimulate descending inhibitory control from the brain using different interventions such as so physiotherapy and interventions, you have to do a pain assessment. I think this is one area that, just like Muhyiddin said, going forward, we need to look at, to take home. You know, for us in the ICU, you need to assess pain. No matter how, you just try your best to see if you can assess the level of pain a patient is. And this can help because there can be communication with the other members of the ICU team for analgesia optimization. And we have to learn also to do our physiotherapy sessions around when the patient has received analgesia, especially if your intervention will elicit a lot of pain in these patients for maximal benefit. So what are the principles of our management for critically ill patients? We have to find a way to minimize pain before the intervention. And one of the ways is to be sure that there's optimized oxygen saturation. If the patient is receiving so liters of oxygen, it can be increased while you do the movement for the patient. You can increase the liters to optimize the level of pain that the patient will feel. Then you have to start your interventions in a gentle and graded way. Then you have to also take care of patient comfort, early mobilization, and doing your respiratory physiotherapies, which mainly is called chest physiotherapy with minimal discomfort. One thing we say for ICU, you fold towel and before you apply your percussion. Don't do it on the bare cloth or bare skin of a patient. All of these are aimed at reducing pain in the patients. So, and this publication published in Springer Nature talks about agitation and pain during physiotherapy in the intensive care. And the study recommended the need for pre-oxygenating patients, explaining procedure if the patients are conscious or cooperative. You can also actually request for appropriate analgesia from other team members, and scheduling therapy sessions when the analgesic administration is at peak. So these are little things that you can really structure your intervention. If I don't know if this is realistic to be asking for, but since our theme for the workshop is pain, and we're looking at all the ways to remove or to reduce pain, and then this is the way to go. Then you have to start from slow intensity mobilization. If you have to do ROM exercises for the limbs of the patient, you have to start from the smallest range, then you take it to the end of joint range, avoiding sudden changes in patient positioning. You can do it generally just doing a graded intervention in a gentle way. And there is evidence for this in literature from one of the International Journal of Health and Allied Sciences, where early mobilization has been shown to be a better outcome than routine physiotherapy in terms of reducing ICU stay, even in mechanically ventilated patients. So in the ICU, we want you to monitor vital signs continuously while you carry out your, and this is an RCT, even though it has a very maybe small patient number. So how do you optimize patients' comfort to reduce pain is by giving proper positioning advice to the patient, using pillows, taking care of pressure areas. We know what we normally do. We apply powder, we massage. Then supporting limbs and devices to avoid traction or pull. To provide warm blankets. Warm blanket can help reduce the discomfort and also reduce muscle tension. So if you want to apply chest physiotherapy for a patient, particularly suctioning, you avoid prolonged suction durations. Don't suction just for the fun of it. And always take out the catheter after a few, at least less than 10 seconds. Provide chest support during coughing. You can teach a patient how to splint while coughing. All is to reduce pain. Then use manual techniques cautiously, like percussions, vibrations. We recommend using a towel as an interface. Then teach supported coughing or coughing wipe also. So this, then early mobilization should also be one of the things that should be incorporated. It should be planned. It should be pain optimized when the patient is in less pain. It should be coordinated with other staff. So our intervention generally include positioning and repositioning. You can actually use heat and cold therapy, even though there are some precautions to observe, depending on the patient condition. Then passive and active ROM, range of motion exercises, breathing control and relaxation, splinting during coughing, manual therapy, and environmental modification. So for positioning, it helps in reducing VE, which is the ventilation perfusion or ventilator perfusion mismatch. Helps to prevent stiffness, and invariably this will help to reduce pain. So when I'm giving the intervention, you have to think around preventive pain, prevention, and managing management. So I really had to do this because I think that we hardly take our IR to the ICU, but I'm not sure. But most often than not, we will not take ice pack to the ICU. But it's quite important that there is evidence from a scoping review that has shown that critically ill patient can actually benefit from, for those who listen to music therapy, but even topical heat and cold therapy. So if you're able to justify, able to see that this patient has actual muscle stiffness, there's nothing stopping you to apply maybe IR for the patient, only that you have to be sure that the patient doesn't have any vascular compromise. Then you can also use cold therapy for post-surgical inflammation in ICU patients, and this has been shown to have very good outcomes. So preventing contractures and joint stiffness, using passive or active assisted range of motion exercises can also be used to prevent pain occurrence in the ICU. So then there is the breathing control and relaxation, which has to do with improving comfort during respiratory distress and reducing anxiety-induced pain. So breathing exercises, usually with device, we have a lot of devices we call the PEP devices, positive expiratory pressure devices that keeps your airways in very positive pressure. And by these are mainly used for increasing secretion clearance in patients, especially those that are dependent on mechanical ventilators or just went from mechanical ventilators without adverse effects. So any breathing control intervention can be actually used to prevent anxiety that may come without such intervention that also induces pain in these patients. So this is image showing how splinting can be done using pillows for surgical and painful sites in patients while the patient is asked to cough to be able to maintain the potency of the tracheobronchial tree. Then also using gentle mobilization of the joints. All of these are important in preventing pain that can occur due to stiffness and other issues around them. So like we noted, it's very important that there's collaboration. I think this is the central theme of my work. You need to understand the pain level of a patient before your treatment. You can actually request for pre-therapy analgesia, or you factor it to your treatment time. There are reports patients who cannot tolerate movement, participation in other protocols in the ICU, and participating in other daily sedation awakening trials. So you can modify. I think this is left to your judgment as experienced clinician. You'll stop treatment when you notice that the patient's pain is increasing significantly, or the heart rate and blood pressure rises excessively. For critically ill patients, these are important things to note. When the saturation, oxygen saturation drops, despite intervention, maybe pre-oxygenation and all of that. When there are signs of agitation in the patient, generally when the patient becomes unstable. So in conclusion, we want to see that pain is common and often severe in critically ill patients. And we know that will play a central role. We can help majorly in identifying pain and noting it. There's nothing stopping you from recording the EMR or patient case folder that the postponderal region on the left of the sternal area is tender. This is this, this is that. You can also help in reducing pain. Depending on the indication, you bring in your therapy adjuncts, you bring in your ice cold therapy, you participate by doing manual treatment for the patient, chest physiotherapy for the patient, and all whatnot. And also in coordination with other staff, then you can ensure a safe, comfortable, and beneficial rehabilitation. We know, lastly, that effective pain management enhances recovery, reduces delirium, facilitates mobilization, and improves outcomes generally in the ICU. and would like to thank you all once again. I'm trying to restrict the presentations to 30 minutes each so that we can finish ahead of 4 p.m. So, Zephyr, over to you.
Okay, thank you, sir. Ladies and gentlemen, if you have any comments or questions on the last presentation given by Professor Jibril, please feel free to ask them in the comment section or raise your virtual hand so that you can unmute yourself and ask the question. Comments or questions, please?
Maybe I'll just proceed. So,
Yes, sir.
if there are questions, they can come in.
Okay.
All right. So another topic that I was given is to talk about physiotherapy management of postoperative pain following thoracic surgeries. So we try to call ourselves cardiopulmonary or pulmonary and physiotherapists at least. And one of the major areas that we come in a lot is surgical patients. And for surgical patients, or post-surgical patient or post-thoracic surgery patient, the pain is one of the important areas to focus on. Somebody is asking, maybe asking about slide. Are we going to give out slide? I'm not sure, but I want you to listen first. So that's by the way, sorry. So a non-reproducible pain is a pain that a patient cannot, that is not localized, that is not repeatable. If you have a pain of cardiac origin, and if you press this part of the chest and the pain is elicited, and you come back and press the same place, and the pain is not elicited, it means the pain has traveled somewhere. So that makes it non-reproducible. I'm trying to, I can't see my cursor. Okay. So like I was trying to introduce, so patients undergo thoracic surgeries or cardiothoracic surgeries for various reasons. And following these surgeries, they become good candidates for some form of therapy or interventions. Some patients also need pre-surgical interventions, but at the moment, pre-surgical interventions are still not very popular, especially in our area. So we only get patients, or we mainly get patients post-surgery. So some of the common surgical interventions that is quite amenable to physiotherapy include thoracotomy, which means opening in the chest. Thoracotomy could be done for various purposes. There's an image here showing lateral thoracotomy. This can be done to do another operation, maybe on the lungs, in the pleura, or to assess other parts of the chest. But you can also see the use of video-assisted thoracic surgery, which is quite common now, and called VATS. And VATS is popular because patients have less complications. So there's also a pneumonectomy, removal of a whole lung. Then for the cardiovascular, there's the coronary artery bypass grafting, which has to do with when a vein is taken from the lower limb and grafted on the coronary artery, maybe following heart attack or myocardial infarction. And also lobectomy, removal of lobe. So these surgeries often produce significant postoperative pain due to several reasons, and these are some of the reasons. Incisions, because incisions are made through the skin, through the viscera, through the muscles, sometimes through the ribs, through the pleura, and we know that the pleura is quite sensitive to pain. So these patients come down with significant levels of pain. Then chest drains are applied. Maybe there is still need to continuously drain secretions. And mechanical ventilation for those that end up maybe in the ICU, prolonged immobility. Maybe the patient has a major surgery and the patient has to be immobile for a very long time. Then in patients that have coughing or deep breathing difficulty following surgery because of the pain. This study has reported that 1 in every 4 patients that underwent thoracic surgery do not only have pain, but go on to develop chronic post-surgical pain. And 1/3 of them, that's 1/3 of the one, are accompanied with neuropathic component. That's the pain with a neuropathic undertone. So therefore, there is need for early prevention as well as aggressive treatment for patients following thoracic surgery to achieve better treatment outcomes. So what are the consequences of operative pain? So once a patient had undergone thoracic surgery, and because of the pain that they have post-surgery, depending on the type of surgery, this pain can limit ventilation. The patient will not want to breathe very well.
And Prof is currently experiencing some technical difficulties, but he'll be back in a bit. So I'm trying to get him back. Apologies, ladies and gentlemen. I'm still trying to get him back online. Apologies, dear colleagues. I just spoke with Prof. He's still trying to come back in. He's experiencing some network-related difficulties, but he'll be back in now.
Hello. I don't know what happened. I just realized I was speaking alone. I don't know how far back I will go. Did I get to this place, Josefa? I don't know.
I think you are on this slide.
Hello?
I'm not sure.
Can you hear me?
Yes, we can hear you, sir.
Okay. All right. Thank you. Okay. The net appear. Sorry about that. So we drugs are non-pharmacologics, and that's the essence of this paper. So for physiotherapy management, we want to position our patients well, supporting them with the right pillows or splints. If you are going to position, you have to change it at least 2 hourly to reduce chest stiffness and pressure pain. There's what thoracic pillows to support the shoulders to reduce. Then there are a host of breathing techniques that you can teach to post-surgical patients, including deep breathing, slow breathing to reduce muscle tension and improve oxygenation, uh, diaphragmatic breathing to decrease upper chest tension and pain, an inspiratory hold whereby you ask the patient to take a deep breath, hold it for 3 to 5 seconds to mimic autogenic drainage, and also to use of support when the patient is coughing, especially along the incision lines, uh, and also without disrupting the sutures. Then mobilization can include bed mobility, sit to stand, walking, shoulder and thoracic mobility exercises to reduce shoulder pain. You can reduce muscles stiffness by heat therapy and so on. Because when you take away the pain, then you are able to do so much more for the patients, including the chest physiotherapy, which includes thoracic expansion exercises where the patient abducts or raises the hand during inspiration and brings it down during expiration to reduce chest wall stiffness. So for percussion, you have to apply cautiously, not directly over the incision or drain sites. Exercises, there are several that are possible, and this invariably reduces pain. Then posture training, with the scapular retraction, don't allow the patient to stroke. So this is one review
He's trying to log back in now. Ladies and gentlemen, we sincerely apologize for the outage we've been having. Prof is currently experiencing some technical difficulties, although he's been trying to sign back in into the Zoom webinar, but he's been logging in and logging back off. So what we've decided is to take a short break and come back around 4:05, and by then we'll try to sort him out and get him a more stable connection. So
Good afternoon. I don't know if someone can tell me how far back I can go, but in any case, I don't think we will spend more than 20 to 30 minutes more. The last talk on red flags is a bit, it's not too much. Sorry about this. I had to look for an Airtel SIM. So, is this a good place to start when it's time?
Yes, sir.
Okay. So we have about 5 minutes. I think many people are yet to join back. Thank you for your understanding. MTN just left completely. I tried a second MTN line, no way. So luckily there was Airtel backup.
Uh, Good evening, ladies and gentlemen, and welcome back to today's session. Professor Jibril is back online, and he will take over from me now and continue with his presentation. Prof, the floor is all yours, sir.
Hello.
Hello, we can hear you, sir.
Okay, I think
Yes,
I
sir,
have
you
to
can
be
continue.
fast. I just got logged out again. I don't know what happened. I'm on Airtel, so the MTN, I can't even use WhatsApp or MTN. Very strange. My first experience about this. So I went a few more slides back so that those who want to catch up can do so. So assessment of postoperative pain. So there is the functional aspect, which has to do with evaluating pain in a patient when the patient is carrying out certain activities. For example, during deep breathing, was there more eliciting of pain or not? And for example, during coughing. So these are things that we take note of case notes, the patient for during PT, then during specific physiotherapy technique. It's important to function, know when the patient is supposed to then there is when you are doing and when the patient is not doing anything, how is the like what is the patient like? Reduce chest action, splitting the chest wall. So the goals generally is to improve ventilation and to prevent pulmonary complications. Also, because you the pain goes to reduce stiffness, to improve mobilities. In cardiopulmonary physiotherapy, what we actually do for patients may just be our normal treatment routine, but in the process, a pain comes in one way or the other. You are either helping to attenuate the pain one way or the other with good treatment strategy. So I brought up this paper, which concluded that amongst other things, the use of multimodal treatment, combining not just medications of different systems in terms of regional or systemic analgesic agents, but probably also the use of non-pharmacological interventions as good ways to prevent even chronic pain syndrome. You recall I said 1 in every 4 patients develops chronic post-surgical pain. So physiotherapeutic which variably side supporting it with pillows ways to reduce especially when to do breathing exercises or coughing. Then we don't want the patients lying directly on the incision side, but gradually from side lying, depending on where the incision site is. Then frequent turning, then use of thoracic pillows. So patients also to carry out deep breathing exercises as a way to manage postoperative pain can actually help to reduce muscle tension, improve oxygenation, lung expansion, and this is better done with optimization of analgesics. That's when the patient has just been administered analgesics. Diaphragmatic breathing can help to reduce upper chest tension and also pain in the upper chest. Also, inspiratory hold can help to improve ventilation and reduce risk of lung collapse. Then when the patient has to cough, he has to use a folded pillow against the wound so that there is no buildup of pressure and aggravating the pain in the suture area. And also helps, there's also need to, and this also helps to reduce incision pain and also while the patient is being cleared of secretions. So in terms of early mobilization, this can also be then there's also shoulder and thoracic mobility exercises. Aim generally is to reduce stiffness in ventilation because the more the lungs is ventilated, the less pain it has, and also to enhance circulation. Circulation stop.
Sir, if you can hear me, please unmute yourself. It appears as if you are muted. I'm not sure.
Yes, I just realized that part of the present. Came back in and thought, and the enhanced circulation with clearing pain mediators. Then I talked about reducing anxiety and sympathetic activation, which is also linked with pain stimulus. So chest physiotherapy comprising of mainly thoracic expansion exercises using targeting the surgical sites. So for example, if you have left thoracotomy incision or lateral thoracotomy incision and left lateral, so you can abduct your left arm while inspiring and adduct while expiring as a way of targeting thoracic expansion, because if the thorax expansion exercises are not done on time, then stiffness occur and the patient continuously stays in more pain. ACBT is another intervention. We don't have time to go through it, but it's also an intervention for clearance of airways and improving ventilation. that can also indirectly help to reduce pain. And also percussion and vibration may be indicated, but this has to come with some caution, especially around the incision and the drain site. Exercises, but this specifically focuses on the joints, the shoulder joints, and the scapula, because these are areas where if it becomes stiff, and then patient comes down with a lot of pain in the upper shoulder region. Then patients have to be taught also postural training, such that they avoid the normally protective rounded shoulder posture and maintain good posture ergonomics that will later improve their function. So this is one paper from Korean Journal of Thoracic and Cardiovascular Surgery, talking about some of the essential physiotherapy interventions following surgical surgery. And the key word there, you can see the third point, is talking about TENS and ice pack, which can also help not only in reducing the pain, especially the postoperative incision pain, but also helps to reduce the need for additional analgesia for these patients. And physiotherapy also can provide some wound support during deep breathing exercises, coughing, forced respiratory techniques, and other range of motion exercises while the patient is still on admission post surgery. So this picture is showing TENS around tracheotomy incision. The TENS, the electrodes are applied around and not over the incision site. Cryotherapy can also be applied when using the technique. Or they're highly sensitive to cold. Others include physician training and, of course, giving proper education to the patients. So there's a need to coordinate with the best when the peak place, and especially when pain can limit breathing and mobility. So some of the precautions will be around the chest drains. Patients with low pain threshold, like older patients or frail patients, those that have slow mobilization, so you don't become overly always out of chest pain for physiotherapists. So just like the beginning of the talk, we said chest pain could have variety of origins. I just added vascular and psychogenic to the list on this part of the talk. So if you're able to properly identify the patterns of the pain, then especially those that may require referral, then it's good for us. So what are the cardiac causes of pain? I think I've talked about this. In angina pectoris, the pain is tight, it's heavy, it's linked with exertion or emotional distress. Somebody just climbed a flight of stairs and he has to hold his chest and sit down. But after resting, then he's okay. Then these are signs that angina pectoris is already in place. We've talked about the pathophysiology of angina pectoris. Then for myocardial infarction, severe crushing, heavy squeezing pressure, it's persistent, that means lasts more than 20 minutes. It's not relieved by rest. The patient may come with more sweating, nausea, breathlessness. So these are important things you may need to look out for. Then pericarditis, sharp stabbing chest pain, which is worse when you're lying flat and relieved when sitting forward, because anytime you lean more forward, there's relief with pericarditis. So this is basically a repetition. Same thing with the pulmonary causes. It's mainly what is in the former beginning of the slides that is being repeated here also. So the importance of repeating all this is so that we can be able to identify the red flags and the part that there may be a need for referral. So this is for pneumothorax. Unilaterally, usually there's breathlessness, no breath sound because you can't hear the air entry in the part of the lungs where it has collapsed or there is a pneumothorax. Then for gastrointestinal causes, it could be reflux disorder or peptic ulcer, esophageal spasm. Then burning retrosternal discomfort in the case of gastroesophageal reflux disorder or disease, which worsens after meals or lying down, which is relieved also by antacids. So for peptic ulcer, the pain is at the epigastric region, radiating to the chest, and peptic ulcer improves with food, which is the opponent of the other one. So esophageal spasm can mimic cardiac pain, and it's often triggered by swallowing maybe food. So this is for musculoskeletal. The three main aspects I've earlier mentioned also is the costochondritis, which is reproducible with palpation because it's localizable. Now, the tenderness usually around the costosternal junction. Then pain increases with movement, twisting, deep breathing when it's intercostal, because the intercostal muscles are highly mobile in moving the rib cage to whether to increase the for the respiratory mechanics, because when they contract, they expand the chest so that the airflow differential, the atmospheric pressure in the airways and within the thorax differential can facilitate respiration. The thoracic spine dysfunction can refer pain across the chest and scapular region. So there is also panic or anxiety disorders related to pain. I'm not an expert in this area, but I think that Mujahid spoke about it at some point. So what are the main red flags that you would want to refer the patient when you suspect cardiac emergency, chest pain, when the patient described with high level of pressure, heaviness, or crushing, radiating to the arm, neck, jaw, with sweating not relieved by rest after 5 to 10 minutes, and maybe in patients with underlying pathology. This can mean a patient can go into cardiac emergency, so you can actually help to direct the patient appropriately. Then pulmonary emergency, when a patient has high respiratory rates or with sharp dyspnea, so there may be pulmonary embolism or pneumothorax, or the patient becomes cyanosed or with sharp fall in oxygen saturation or coughing up of blood. Then for aortic dissection, which we have shown, could be due to sudden tearing when there's unequal BP or pulses between the arms, often accompanied by neurological symptoms. So infections, when there's fever accompanying chest pain, high temperature, productive cough, low BP, rapid pulse, showing signs of sepsis. Then when the pain is also non-mechanical, because you can reproduce it with movement, and it occurs at rest, worse lying down, improves when leaning forward, and this is classical of pericarditis. These are also red flags to watch out for. Then pain with abnormal vital signs, a patient having less than 50 beats per minute or more than 120 beats per minute, systolic more than 180 or less than 90, SpO2 less than 90 or dropping rapidly, respiratory rate more than 30. Signs, these are signs of. So in summary, we want to see a red flag and possible condition. This is just summarizing what I've just read. So if pain is not reproducible, there might be cardiac cause. If there is hypoxia, tachypnea, is respiratory incline, worsen when lying down, pericarditis, with fainting, it can be arrhythmia or severe cardiac disease. With cough, fever, it could be pneumonia or pleurisy. Tearing pain at the back, with breathlessness, pneumothorax, pulmonary embolism. Heavy chest pain, crushing is unstable angina, which is another step beyond normal in the classification of angina. A myocardial infarction. So chest pain, from all the 4 presentations I've made today, can be best described as a diverse pain that largely depends on an MDT approach in cardiopulmonary patients. So there is need to refer undiagnosed chest pain when red flags are present, if you happen to be the primary contact or the person managing a patient, based on the explanations that I have given. I would like to thank everyone for staying to the end. I'm sorry for the network glitches. I didn't anticipate it at all. Thank you so much for your attention. Uzaifa? Josefa?
Good afternoon, everyone, or evening, everyone. Thank you for staying with us from morning till this time, despite our various schedules and activities. It is truly a very resourceful presentations. So the presenter is waiting for any question, response, or comment from the participant. Thank you.
If they don't have, I also have 10 MCQ. So we'll go one by one.
So you want to apply the class
No,
technique?
it's
Okay.
just, we will just put the answer in the chat box.
Okay. Okay, so I think the audience can hear what you just said. So please,
I'll wait for
any
for correct answer reward for correct responses.
I didn't hear you.
Any reward
If,
for correct responses.
Asking for reward.
Is it?
And I'm saying that will be sponsored by the person asking the question.
From
making inquiry, sorry. The person making the inquiry.
Yes, you're absolutely right.
Yes.
Hello.
Yes. Yes. Questions, comments, please.
Am I allowed to talk?
Yes, sir. Go ahead, sir.
Okay. I would like to appreciate the presenters and as well as the participants for this marathon webinar, so to say, or a workshop. It is really, really educative and a kind of refresher course, especially while dealing with pain, especially in our day-to-day clinical practice and maybe for other research purposes. So I would like to call upon all of us that pain is something that we shouldn't toy with. We should incorporate it, and it shouldn't be a kind of something that we should domesticate in our practice. Whenever your patient maybe complain to you that he or she has a pain at a particular part of the body, so that has to be noted, because pain is always telling you that there is a pathology or a disease happening within that individual, and it should not be ignored and it should not be overlooked. So incorporating pain management and documentation of pain is very essential to us as physical therapists, as the various presenters have mentioned also, especially in the documentation aspect. So whenever you have your patient, irrespective of maybe musculoskeletal, neurological, cardiopulmonary, and the rest. So whenever there is a patient, as much as possible when there is pain, we should try as much as possible we document that finding of pain, because it is very important in the clinical practice setting. So by and large, I appreciate everyone. Thank you so much.
Thank you very much, Dr. Adamu, for your for the comments and the insight. These are well noted and will be considered. I'm sure we are going to look into that in our various practice. I want to hear once again from Dr. Ashur Hamza.
So maybe we'll go to the quiz before it's too late.
Okay, sir. Naga Ashur, sorry. Okay, we can go to the quiz. Yes, sir, we are waiting.
So I'll be looking at the chat box. I will not give you time to copy to check for answer. So the first person to answer within the first 10 seconds.
Okay, what is the next? We are going to voice out the questions and people will respond on the
yes,
chat.
And people just type the answer.
Okay.
And you just type the answer in your chat box.
Okay, how long do we have to respond?
The question is already out, so your time starts now. Oops.
The screen is gone.
Sorry, I mistakenly shared the answer. Yeah, I mistakenly shared the answer, so I have to.
We're able to see that.
Okay.
Everybody is
So we
bonus.
have 10 seconds. 10 seconds. Nobody has sent any answer. Unfortunate. So Aisha Bakar, she said, all right. Thank you for your attempts. I think 2 people got it right. So question 2. So question 1 is, which type of pain is the most common after thoracic surgery? And the right answer there is somatic pain from chest wall incision. So
Okay.
thank you about that. So question 2. So you have 10 seconds. Which breathing techniques help best to reduce postoperative thoracic pain? Well, only 2 people are attempting.
I think they are from cardio now.
Yes, they are
Yeah.
they are from your area of specialization. So they should
Uzaifa,
be
you are
doing.
copying from Rashida. So thank you. The answer is correct. It's D. Helps to reduce postoperative thoracic pain. Then question 3 is before us. You have 8 more seconds. Uzaifa, number 1. Tasneem, yes.
This one, even people in Europe can respond.
Okay.
Thank
you. I think question C, option C is correct. In critical care, uncontrolled pain may lead to physiological response due to increased sympathetic activity. Question 4, maybe we'll reduce the time to 5 seconds. Which scale is most appropriate for assessing pain in sedated ICU patients? I talked about this during our presentation. Maybe we're not listening. Okay, Aisha. Bapa, you are not attempting for somebody de magana kudi.
They are moderators. They are moderators.
Okay, thank you very much. Rashida, are you together with Aisha? Maybe you're in the office together. Thank you. So the
No,
correct
sir, I'm
answer
at home. Sir, I'm
so
at home.
correct answer is behavioral pain
We are not
scale.
together.
We
So
are not
the
together.
next is question 5. An important non-pharmacological strategy for reducing postoperative thoracic pain during coughing is. Everybody should get this. Thank you, Mr. Ebe Emmanuel. Okay. Correct answer is splinted coughing. And number 6, which physiotherapy intervention helps to reduce pain associated with chest tube insertion? Number 6. Nobody? Wow. No, A is not correct. It's straightforward now. Yes, Rashida, yes. The correct answer is B, gentle thoracic mobility exercises. So number 7, epidural analgesia after thoracic surgery improves physiotherapy outcomes by, I don't think we covered this, but somebody should be able to try. No, it's not C. How can you say increased risk of atelectasis?
It was a mistake, sir. I was. It should be B.
Anthony, on the
B,
big, the biggest Yes, Rashida, I think you got it. It allows for earlier deep breathing amortization. Number 8, which component of pain assessment is most essential before initiating early mobilization in the ICU? This is tricky. I don't think we covered it directly, but you should be able to use common sense here. Yes, the correct answer is A, sedation level. Number 9, a patient reports increased chest pain during incentive spirometry. The best physiotherapy action is to what will you do as a physiotherapist? Somebody is doing intensive physiotherapy, spirometry, and is complaining of pain. Any other option? Yes. I don't know why Rashida is copying Aisha, but the correct answer is B. Yes, you reduce the intensity and provide coached breathing. Maybe the patient is not doing it well. You don't discontinue completely at first, unless you get other outcomes indicating such. So the last is number 10. What is the primary benefit of multimodal analgesia for post-thoracic surgery patients in physiotherapy? I talked about multimodal treatment earlier on. Yes, at least another any. Right, let me just say that. So the correct answer is B. Thank you so much, everyone. I believe we had some fun. Some people are always afraid of assessment. Most lecturers don't want to be assessed. That's why I cannot see anybody. So, Bappa and Wale, congratulations for taking last.
Sorry,
I think the
sorry, Prof. I'm not. My major issue is I'm using phone. I could not be able to read before you move the slide. I'm not wearing my glasses, so that was why.
Best response is Aisha.
So who is the winner? The winner should be announced and should be recognized and awarded.
So thank you very much. Thank you, everyone. Thank you, the resource person, the presenters, Professor Jibril,
okay, NSP can
Dr. Mujahid, Dr. Muhyiddin. We all appreciate the resource person, and this is the first part of the presentation. By next week, God's grace, we are going to take the second part, which incorporates orthopedic and musculoskeletal assessment of pain, and also neurological assessment of aspect and assessment of pain also, which we are going to take the other half of the presentation, including the presentation that we are supposed to take from Professor Wadaru, who is not available today because his flight was rescheduled and he couldn't attend the webinar today. And before closing, maybe I'll hand over back to Jose since he's around, or I'll hand over back to the Secretary Education Committee, Dr. Tasnim. I think any of them can respond and give a closing remarks so that we can close.
Thank you very much for the comments, sir. And as you've already said, I would like to also take this time to appreciate all our facilitators for taking time out of their busy schedules to impart this important pieces of knowledge on us, which I'm sure is going to transform the way we see patients who complain with pain to us. And secondly, I would also like to thank the attendees who also believed in the importance of this crucial topic and took time out of their busy schedules, also almost 8 hours, to sit with us and to learn with us. So thank you very much for what you've done, the presenters, and thank you very much to the attendees for your time. And I would like to say goodbye and until next week on the same time for the same presentation. Thank you very much.
Thank you, sir, too.
Thank you too. We are very grateful for this wonderful presentation.
Thank you, man.